Good morning, good afternoon, good evening. A very warm welcome, everyone, to RCSI University of Medicine and Health Sciences and to the second day of our inaugural Dublin meeting in patient-centered global surgery. Last night in Dublin, we held an on-campus event with over 100 people joining us in person. Today, we are fully online and delighted to have an international audience of over 200 delegates from 20 countries. We're crossing at least 15 time zones. You're all very, very welcome. In 2022, 5 billion people worldwide do not have access to safe, affordable, and timely surgical and anesthesia care. RCSI established the Institute of Global Surgery to address this global crisis. The Institute builds on our 14 years experience in research, education, and training collaborations with partners in sub-Saharan Africa, and it reflects our university-wide commitment to the UN Sustainable Development Goals. This Dublin meeting in patient-centered global surgery puts the spotlight on research that focuses on patients and puts them at the center of all our efforts in global surgery. At our event last night, we discussed how there can be no safe surgery without safe anesthesia. And we were delighted to have His Excellency, Dr. Mboki Uli Subisia, President of CONEXA, the College of Anesthesiologists of East, Central and Southern Africa, and Tanzanian High Commissioner to Canada, to join us as our keynote speaker. I'd like to very warmly welcome the 3 keynote speakers who will be joining us live online today. Our first keynote speaker in a couple of minutes, seen now on screen, will be Tansri Dr. Noor Hisham Abdullah, Director General of the Ministry of Health of Malaysia. He himself is a surgeon who we've had the great personal pleasure of welcoming to RCSI in 2019. After the break, we will have Dr. Alessandra Colainanni, Assistant Professor at Oregon Health and Science University. Then after the second break, we'll be joined by Professor Agnes Binagwaho, Vice-Chancellor at the University of Global Health Equity in Rwanda. I won't go into long introductions of these distinguished speakers, as they will be fully introduced before they speak. But I do want to acknowledge that all 3 readily, when initially approached months ago, when we didn't know what format this meeting would be taking, agreed to speak. I'd like to convey my deep appreciation to them for their commitment to joining us today, despite their very busy schedules. I'm looking forward to all 3 presentations. I'm also looking forward to the 8 scientific presentations that we made during the course of the day. There was a huge response to the call for abstracts when it went out, and the review committee faced a very tough job of narrowing them down to just 8 papers for presentation today. We look forward to hearing from each presenter, and at the end of the meeting, the winners of the awards for best abstracts will be announced. I understand that this Dublin meeting, particularly because it's online, is running to a very tight schedule. So it now gives me great pleasure to hand over to Professor Mark Schreim, the O'Brien Chair of Global Surgery at RCSI, who will take you through some housekeeping for the day. Again, a warm welcome to you all. Thank you, and over to you, Mark.
Thank you, Professor Kelly. Thank you, all of you, for being here. And also, I want to add my thanks to Professor Kelly's, to Tansri Dr. Noor Hisham, to Dr. Agnes Binagwaho, and to Dr. Alessa Colainanni, our keynote speakers, for taking the time across a bunch of different time zones to be here with us today. Professor Kelly has gone through the order of services. Just a couple of housekeeping events. The in-person talk that happened last night, there will be a video available to all presenters after our meeting concludes today, to all delegates, to all attendees after our meeting concludes today. We will send that out to you all. A couple of other general housekeeping matters. There will be 2 breaks, as Professor Kelly has mentioned, one at about 11:40 GMT and one at about 2 p.m. GMT. Those breaks will be approximately 15 minutes to half an hour. Please stay online for those breaks. We will not be going to different sessions. So this session will extend for the entire 10 a.m. to 4 p.m. length of our conference. Finally, there is a Q&A box on your screen. Please feel free to make liberal use of the Q&A box. We will moderate some of the questions and ask them directly to the presenters, but a lot of us will also be online and be able to answer those questions via the Q&A box itself in real time. One last thing, if you're having difficulty with the platform itself, there should be a support button on the upper right-hand side of your screen that you can use to get help for the session itself. I think that is all I have in the housekeeping. So with that, let me turn you over to Mr. Eric O'Flynn. Eric is the Program Director for Education, Training, and Advocacy here at the Institute of Global Surgery at the RCSI. Eric has been working here in the global surgery space for well over a decade. Many of you will have interacted with him and will know him and his work. Eric will be introducing our first keynote speaker. Eric, over to you.
Many thanks, Mark. I see that just before I introduce our first keynote speaker, I see Professor Kelly may have his hand raised there.
Sorry, Mark, or sorry, Eric, no reason for my hand to be raised. It must be a slip of my mouse, I suspect.
Great. Okay, so I have the distinct pleasure of introducing Tan-Sri Dr. Noor Hisham Abdullah. And as Professor Kelly has said, we're delighted to have him back in RCSI, even if virtually on this occasion. Dr. Hisham Abdullah is a senior consultant surgeon in breast and endocrine surgery in Putrajaya Hospital in Malaysia, and has held the post of Director General of Health in Malaysia since 2013. His area of expertise is in breast and endocrine cancer, having trained in Malaysia and with the Royal Australasian College. And he has numerous papers and textbook chapters in endocrine surgery. He chairs multiple medical professional councils and national level technical committees with policy involvement in global organizations such as the World Health Organization, the Drugs for Neglected Diseases Initiative, the International Society of Surgery, and he is chairman of the Asian Association of Endocrine Surgeons. Dr. Hisham Abdullah has been conferred numerous local and international awards, excuse me, including the prestigious Fellowship ad hominem of the Royal College of Surgeons of Edinburgh in 2018 for his contributions towards healthcare. In 2019, he was given the honor to deliver the distinguished Martin Allgauer Lecture at the 48th World Congress of Surgery in Krakow, Poland. His special interest lies in enhancing universal healthcare coverage to marginalized communities and bringing personalized healthcare back to the community and home through digital technology and creative innovation. I'm very much looking forward to hearing from Dr. Hisham Abdullah what patient-centered global surgery means to him as a surgeon, a policymaker, a Malaysian, and indeed for the WHO Western Pacific region and ASEAN region. And I just encourage all of our attendees, as Prof. Schreim has said, there is a live Q&A function. Please don't wait until the end of Dr. Hisham Abdullah's talk. Please do put your questions in as soon as they occur to you, and we'll have them ready to go at the end of the talk. Tan-Sri Dr. Noor Hisham Abdullah, over to you, sir.
Thank you very much, Eric, for your kind introduction. First and foremost, I'd like to thank the organizer, the Institute of Global Surgery, RCSI, University of Medicine and Health Sciences, for having me as a speaker today. Allow me to share our global surgery initiative in Malaysia. Next slide. Surgery is indeed a neglected component of public health, and in 1980, Professor Dr. WHO Director General Dr. Hafdan Mahler clearly stated, and I quote, "Surgery clearly has an important role to play in primary healthcare, and yet the vast majority of the world's population has no access to whatsoever to skilled surgical care, and little is being done to find a solution." Next slide. And we have heard the Global Surgery Initiative and the Lancet Commission on Global Surgery by John Mera, published in 2015, highlighted 5 key messages. First, 5 million people lack access to safe, affordable surgical anesthesia. 140 million additional surgical procedures are needed each year to save life and prevent disability. 33 million individuals have catastrophic health expenditure due to the payment for surgery and anesthesia each year. Investment in surgical and anesthesia services is affordable, saves life, and promotes economic growth. Surgery is indispensable part of universal health coverage. Next. Now, since 2015, surgery has been increasingly recognized as an indispensable part of healthcare. And the World Bank in 2015 published Disease Control Priorities, the third edition, on essential surgery. And obviously, Global Surgery 2030 report, the Lancet Commission on Global Surgery, was published in April 2015. More importantly, in the 68th World Health Assembly, Resolution WHA 68.15 highlighted the strengthening emergency and essential surgical care and anesthesia as a component of the universal health coverage. Next. And beyond the Lancet Commission, this is where I think we need to come with the amicable solution of global surgery to address some of the issues. And the key points is, whatever we have learned in this COVID-19 pandemic is that we need to work together as a team. And it's very important for us to look into policy making that is actually enhance the role of non-state actors in global surgery. And second is, how do we work in partnership with the NGOs and etc. Third, looking into establishing training hubs. And this is very important for us to work with the local partners. Last but not least, to enhance the multinational collaboration and research between upper and lower middle income countries. And the guiding principle that we have is simplicity and ensure that there's quality and safety of care. More importantly is a point of care, meaning bringing the services to the community. And number fourth is the cost effectiveness and high impact, reasonable cost and good outcome. And the surgery that we embrace and even practice must be replicable and focus mainly on day care surgery. Next. Now, the essential surgical list development, here I think it's very important that the first coordinated global effort to meet the needs of the emergency anesthesia and surgical care in primary health facilities meeting was held in Geneva in 2015. And in this meeting, the WHO Global Initiative for Emergency and Essential Surgical Care was established in 2005. Essential Surgical and Anesthesia Care List was developed to assist country groups in providing basic surgical and anesthesia care at their respective country. Next slide. More recently, the strengthening of global surgery in the Western Pacific region. This is a clear message from member states of WHO Western Pacific region in their adoption of the action framework for safe, affordable surgery in the Western Pacific region for 2021 to 2030. And this was discussed during the 71 session of the Regional Committee for the Western Pacific region. We all know that 30 to 40% of the global disease burden is surgical based. And this action framework 2021 to 2030 is provide a useful tool to improve patient safety, to improve access and affordability of surgery and equity. More importantly is to enhance creative ideas and innovation to address a global surgery and advancing the region universal health coverage and SDG, and obviously to enhance the region for the future towards the healthiest and safest region. Next. Now, the operational shift in the action framework for safe and affordable surgery, we have 4 shifts. The most important is health beyond the health sector. Every sector, it will be the health sector. More importantly, to be inclusive. And every ministry is the Ministry of Health. The most important ministry is Ministry of Finance to support global surgery. Second is that we're looking into the targets and working backwards to achieve the targets. And third operational shift would be bottom up. It means looking into the issues and challenges of the community before we can come up with a plan and strategy implementation of the global surgery. Last but not least is driven by the country impact, developing and strengthening the information system as well as technology in the implementation of global surgery. Next. And the Global Surgery Framework Essential Surgical List was developed from October 2018 to January 2019. And here you can see WHO Global Initiative for Emergency and Essential Surgical List. But we just highlight 5 important surgery. And in 2016, we noted that from 110 procedures being done in Ministry of Health hospitals, 40% of the surgery basically encompass hernia repair, incisional drainage, appendectomy, male circumcision, and excision of lumps. So if we can actually focus on these 5 simple operations, we can offload 40% of the workload in the major or minor specialist hospitals. Next. Now, improve access centers, 20 Malaysian hospitals with essential surgical services. Now, in the Peninsular Malaysia, we have 8 hospitals in the rural area. In Borneo, 7 hospitals in Sarawak, and North Borneo, 5 hospitals. And here, I think these are the main hospitals without specialist services. But how are we able to provide services in these rural areas? Next. And we started in January 2019, our pilot project in one district hospital by the name of Sabak Bernam, which is the 93-bedded non-specialist hospital. And we noted the average BOR is 35 to 40%, length of stay about 2 days. Majority of cases, all emergency and elective surgical cases, were referred to the nearest hospital with specialist services about 120 kilometers away. So now, using WHO tools for situational analysis to access the emergency and essential surgical care, so we look into the areas of the infrastructures, capital outlay, human resources required, disposable items, intervention that can be done and readily available, and obviously supplementary equipment needed to perform these 5 simple operations, which can offload and decongest some of the major hospitals in Malaysia. Next. Now, more importantly, is looking into the timely access to essential surgery, the bellwether access in Malaysia, whereby when you look into what is the population access to surgical and anesthesial care in Malaysia. So when we look into the Peninsular Malaysia, we are able to achieve 100% of bellwether procedures. And in East Malaysia, in Borneo, only 21% of the national population is mainly in Sarawak and Sabah. We are able to achieve about 71%. So there is a universal coverage in Peninsular Malaysia, but not in Sabah and Sarawak. That is Borneo. 2 million people in the East Malaysia do not have timely access to surgery. And this may be due to the logistic geospatial understanding of the population access to essential surgery is necessary for the national surgical health planning. So how can we come together to address these issues to provide care in the community? Next. Now, this is a distribution of a hospital in Borneo. You can see that every state, we have a state hospital, and in Sarawak as well as in North Borneo, Sabah. And we have a major specialist hospital, mainly 3 in Sarawak and 3 in North Borneo, Sabah. And we have minor specialist hospital and the white non-specialist hospital. So we are using the non-specialist hospital to train our personnel, human resource, and to make it a global surgery initiative. Next. Now, more importantly, there's 3 forms of delay. Delay in seeking behavior, in seeking care, more perhaps due to the health-seeking behavior. Second is mostly is delayed in terms of in reaching the care. This will be due to the logistic and the geospatial distance. And third will be delayed because of the in receiving care due to the congestion in the respective hospital. Next. So when we look into the distribution of hospital in Sarawak, for example, you can see in Lawas district, that Lawas Hospital, we have the LSCS surgery provided, but not essential surgical services. And they have to cross over to Brunei and to reach Miri Hospital. Likewise, the hospital in Limbang, they have to cross over about 188 kilometers before they refer to a major specialist hospital. And likewise, you can look into the other area, for example, Dalat, they have LSCS surgical procedures provided in the operating theatre, but no essential surgical services before cases are being referred to a Bintulu hospital. So, and when we studied in terms of the logistics and how to improve the global surgery and surgical care in the rural areas, our aim is actually to bring the services to the community rather than they coming to the hospital unless they have to. So the first initiative is decongest some of the services, as what we have mentioned earlier, the 5 operations that can be done in the rural hospitals. Next. So what we have done here, for example, in Lawas, 259 kilometers to Miri Hospital and 183 kilometers to Queen Elizabeth Hospital in North Borneo. So we have the essential surgical services as well as the LSCS being provided. And also we are identifying some of these hospitals that we can upgrade and provide the services. More importantly is to train our manpower and human resource to perform such surgery in a remote area. Next. And this is a global surgery achievement, and we have a target. Access to bellwether hospitals, we are able to achieve to date 94%, whereby in West Malaysia 100%, in East Malaysia 73%. So we still have room for improvement. And when we look into the workforce density, is 12.3 per 100,000 population. So our target in 2030, 20 per 100,000 population. At the moment, we can achieve 62% surgeons, anesthetists, and obstetricians. And when we look into pre-operative mortality reporting, we are able to achieve 92% at the moment. So our target to achieve 100% by 2030. At the moment, our targets are 92%. Next. And these are 16 global surgery hospitals as of February 2022. So at the moment, we have 20 hospitals being identified in the rural areas. And this is why I think it's important for us to optimize our resources available in the rural areas, especially in the human resource. Next. And if the district hospital have high volume of surgical referral, then we will upskill and give and privileging the medical officer in the district hospital, i.e. train them in the specialist hospital for a certain period of time, at least 6 months when they are well versed in the surgery, and then we send them back to the district hospital. For the moderate volume, then the medical officer from the lead hospital will provide some form of services visiting to the district hospital. For the low volume, we have this cluster hospital services whereby it's been covered by the nearest specialist hospital. Next. Now, the global surgery implementation in a district hospital by the name of Greek Hospital, first surgical procedures was performed on the 14th of July. There's hernioplasty. And we trained a medical officer from a major specialist hospital for some time, and once we ensure that the competency has been achieved, and then we send this officer back to the district hospital, and they can actually perform some of the surgery as mentioned here: excision biopsy, hemorrhoid bending, IND, male circumcision, hernioplasty, wound debridement, excision of lumps, and etc. So these will take at least 40 to 50% of the workload from the specialist hospitals. Next. And this is another hospital in the peninsula, Gua Musang, a non-specialist hospital, 90-bedded district hospital, and too far from a specialist hospital care. And the functioning OT is available, and the BOR is only about 65%. Again, using the same concept, we are able to manage some of the patients in the district hospital, and we do not need to refer cases to a specialist hospital. Next. And this is another one, the Mersing project. There is a global surgery initiative in the Mersing Hospital, 70-bedded hospital. VOR is about 48%. More importantly is that the services now, like appendix, IND, hernia, sozorization, second stitching, all can be done either local or general anesthesia in the district hospital. Next. And during this pandemic era, it has disrupted our routine surgical services and elective surgery cancellations due to the COVID-19. It was estimated that 82% of the benign surgery and 38% of the cancer surgery was delayed or cancelled during the peak of COVID-19 pandemic. So we have a backlog of about 50,000 cases. And even if we were to follow the routine cases to be done, elective cases to be done in a hospital, it would take some time, at least a year, before we can clear the 50,000 cases. Next. So we have started initiative. Example is that weekends operating theatres refer some of the cases to the private hospital. And this is another initiative, the Mass Urology Surgery Initiative, whereby if you were to look into our cases backlog, 57,355 cases in September 2021, and 93.8% are surgical based, and 3,733 urology backlog cases as of September 2021. So what we did is that we bring the human resource, the private sector, public sector working together as one. And this is the private surgeons coming to the public hospital pro bono to perform the percutaneous nephrolithotomy PCNL. And we managed to do 62 PCNL within 4 days, and reduction in time and complication. The more you do one procedure, the more efficient you are, and you can bring down the operating time and also reduce the complication. All the 61 patients were discharged the same day, and one stayed overnight. Next. This is another a mass cataract surgery initiative, and one of the discipline that been delayed in terms of surgery is a cataract operation. As of December 2021, there were a backlog of 16,288 cases, and a cataract operation is the most affected procedure in ophthalmology. So here in one hospital, Kota Baru, we managed to do 70 cases in 3 days, and recently in North Borneo, that is in Tawau, a small district hospital, we managed to do 166 cases within a period of 7 days. Again, so we bring the resources from the public sector, private sector, and coming together as one, and also some of the private hospitals and public hospitals working in collaboration to clear the cases. Next. And this is another innovation that we had, Cataract Surgery Center, bringing healthcare closer to the community. Instead of doing the operation in the hospital, here one NGOs provided us with 4-story buildings next to a coffee shop and next to a car yard. But here you can see we have 2 operating theaters. We started operating from early 2013 until recently, the census from until 31st of December, we managed to do 20,986 cataract operation. Per day, I think we can, 2 theaters, 1 theater can do about 15 operations, and 2 theaters about 30 operations per day. And with this center, we managed to cut down the waiting time from 6 months to 3 months, and eventually now is 2 weeks for a cataract operation in Malaysia. And the cost of surgery is only about £20. Next. So, and we look into the outcome because there's only 1 procedure been done in this center. And you can see the baseline national rate of complication is 0.2%. That is endophthalmitis. But in this cataract center, the complication is very, very low. And more importantly, the visual outcomes after 6 weeks is better than the national rate of 85%. That is 94.0%. Next. And another initiative that we have is the Putrajaya Low Risk Birthing Center. So we realized that the green cases have been admitted to the specialist hospital, and that actually congests our hospital. So we use a multi-purpose hall, convert into 6-bedded labor room, and we managed to clear some of the cases. And this is something that we work closely with NGOs and organizations to decongest our hospital. Next. And this is another field hospital that we participated to provide universal access to safe, affordable surgery in Cox's Bazar, Bangladesh. We established this hospital in November 2017. Almost for 3 years, we are there. We have managed to provide some of the services, treated about more than 108 people. We managed to perform 3,500 surgery, including 900 high-risk operation in Cox's Bazar. This is a field hospital, mobile field hospital. We are able to do laparoscopic surgery, ONG, orthopedics, and etc. Next. And this is the concept of a field hospital. Out of nowhere, we have our generators and we have ICUs, imaging, etc. So these are some of the services that we can bring to the community if needed be. Next. So I have the privilege to visit this Malaysian field hospital in Cox's Bazar, and we are able to. I was able to perform 6 operations there, especially the huge and large thyroids. This is something that I think is very interesting, that if we can have the facilities, mobile point of care, bringing to the community, and this will help to reduce some of the issues and challenges that we have for global surgery. Next. And although we do know that in every crisis there's opportunity, and the challenges we see here, for example, during this pandemic, COVID-19 era, increased surgical workload, backlog of surgical cases, increased waiting time, complex surgical decision because of the COVID-19 infection, and healthcare workers' safety issues, resource constraint, supplies chain interruption, etc. But it gives us the opportunity to have the situation analysis and decision making, improve communication, teamwork. The most important is coming together as one. So if there's anything we have learned from this pandemic, is that we cannot work in silo. We need to work as a team. And bringing our expertise together, public sector and private sector, the whole government and the whole society approach, and managing the stress as well as disturbance, fatigue, and etc., and flattening the hierarchy. And we have one goal, that is actually to reduce the backlog cases following the pandemic COVID-19. So I think these are some of the opportunities that we have, and we continue to explore new ideas, new creative ideas and innovation to improve our access of global surgery. So we have actually done global surgery in Malaysia in the rural areas in 20 district hospitals manned by a medical officer. So we hope that we can continue to provide services and to improve more complex surgery in the rural areas in our global surgery initiative. With that, ladies and gentlemen, thank you for your attention. Thank you.
Thanks, Dr. Hisham Abdullah. Many thanks. That was a really fascinating presentation, and it's almost it almost makes one's head spin the amount of progress and different initiatives that you've undertaken there to provide surgery to the people of Malaysia. So that's incredibly impressive, and thank you for sharing that experience with us. For the attendees, again, I'd encourage you to put your questions into the live Q&A section, and we'll aim to get to most of those. But I might take a moderator's privilege and start off with a question. You mentioned earlier on that every ministry is a ministry of health, and later then in your presentation you talked about a whole government approach. Can I ask, as Director General for Health, how does one influence the whole of government, and what are the roles for the, let's say, the departments and ministries that are not usually considered as having a strong influence on health?
I think this pandemic COVID-19 has given us the opportunity to bring people together. I think because health is the wealth of the country, and we have a coordinating agency. We call it MKN, and every morning that we sit together with other agencies as well to provide services. For example, when we look into admission to the hospital very congested. We need, in terms of temporary hospitals, and then we can make do with some of the convention centers and etc. So that is being done by other agencies like NATMA. This is an agency being formed under the Prime Minister's office. So they provide the infrastructure, we provide the services. Again, we work closely with the armed forces. They help us in terms of to coordinate and provide the services in the rural areas and etc. So I think this pandemic is given us the opportunity to improve our coordination and working together with the other ministry. And obviously, before this pandemic, health may not take the front seat, but now with this pandemic, because we try to balance life and livelihood and health and economy. So we get a lot of support from the Ministry of Finance in terms of equipment, in terms of human resource, and etc. And we work with the private sector. We managed to have a pro bono in terms of getting the specialists from the private hospitals coming together and then to help us to clear some of the cases, as you can see. So I think this pandemic has given us the advantage and also the opportunity to work closely as a team. So this is why we emphasize, this is a whole government and a whole society approach to solve a problem. Now, if we can use the same model for pandemic COVID-19, we can use the same model for global surgery. So I think this is something doable if we put our hearts and mind together so we can achieve the targets that we have set.
Fantastic. Every challenge has its opportunities, indeed. And just to pick up on something that you've mentioned just there, and came through quite strongly in your presentation, you talked about surgery and healthcare outside traditional settings, and I think you gave the example of cataract and the maternity services. Do you see more opportunities for surgery outside those settings and for mobile surgery? What more can be done, do you think?
Yeah, first I think we need to look into our strength and weakness. For example, in Malaysia, we already have the district hospital, but because majority of the cases been referred to the specialist hospital, so underutilization, not optimized. We have 2 operating theaters there, but most of the cases been referred and is meant by medical officer. But now we need to train the medical officer. We need to train the assistant medical officer to provide a GA, for example, and some of the surgery. For example, if you are able to do local cases, it can be done in a district hospital. You don't need to refer to a specialist hospital. And as I mentioned, that 5 simple operations can offload 40% of the workload. And even if we are able to do colonoscopy and etc., train our medical officer, registrar, to do some of the complex cases, and they can be posted in the major surgical department and then attain competency and etc. before we send them out. I think this is some of the initiative that we have done, and so far we have proven to show that our performance, for example, in cataract operation, we also use the cumulative sum to measure the performance, whether the trainees can achieve the performance or not. And every surgery, they have to key in the information using IT and etc. And we can chart the performance. And once they can achieve that performance, we can send them out in the district hospital. But we need to provide some of the equipment, looking into the disposable and etc. So I think we try to use whatever we have to optimize them during this period of time.
Fantastic. A question from one of our audience members, Dr. Robert Riviello from Rwanda, who says that he was very impressed by the list of opportunities that you listed because of COVID. He says these were mostly non-technical skills. How have you encouraged, developed, or envisaged the expansion of these skills and opportunities, and how should we encourage the development of non-technical skills?
Now, see, the technical skills come from the technical people. We can train the skills. but the availability, we need to engage with other ministries, other agencies to bring the services together. For example, we talk about the field hospital. So we have empowered the armed forces, in terms of to provide the field hospital, but we provide the skills and technical support. So I think rather than we focus into every area, so the fragmentation in terms of technical skills come from Ministry of Health, but the facilities is being done by someone else, and actually bring all the expertise together. So it's not only the Ministry of Health that is actually involved, but the whole agency. So, like for example, transport, we get the Ministry of Transport to come in, and funding, we get the Ministry of Finance, and NATMA, for example, taking care of the services, then it comes under the Prime Minister's department. So I think all agency comes in to provide a comprehensive, holistic approach, and we only play one part, but the running of the services, managing the services is not the Ministry of Health. I see this is the partnership that we have, and more importantly is that we need to look into the situation analysis of and awareness at each ministry, and each ministry probably rather than duplicate the services, and we do not duplicate, but we enhance the ministry's responsibility. Each ministry and have their own responsibility. So getting the people together and can do endless possibility. I think this is why we have shown some of the collaboration with them, and flattening the hierarchy. It's not the Ministry of Health, it's not the armed forces, but working together as a team. So I think each ministry and individual knows our responsibility during these trying times. And I'm sure if we do this, we can adopt what we have done for pandemic COVID-19 in global surgery.
That's great, and I think many countries, perhaps our own included, have a lot to learn from the Malaysian example of coordination between different ministries and different parts of government. It's very impressive to hear about. I want to ask a little bit about the training of medical officers in basic surgical techniques that you talked through in some detail. So, would you be able to tell us a little bit more about after they receive the training and return to their posts in the non-referral hospital and are performing those 5 basic procedures that you talked about? Is there a system of communication, supervision with the referral hospitals, and how does that work?
Now, we started this concept of cluster hospital, which means a main specialist hospital, then they comes and there are 3 or 4 district hospitals in terms of under the cluster hospital. So there's actually a core hospital providing the hub of services in the district hospital. Now, the medical officer, although trained in the specialist hospital, eventually when we posted them back to the district hospital, they have the communication. It's not visiting anymore. It's actually part of the team. And so we can downstage some of the procedures to the district hospital. They can perform in the district hospital. So we make sure that the medical officer is not lost, and they have a communication in terms of, now we have the technology. Even doing surgery, for example, they can view, in terms of the video call, and can see, and we can provide the advice or even the necessary instruction during the operations. So I think we are also using technology to communicate. And you can do a virtual round and consultation, a virtual consultation. If needed be, then we refer the cases. If not, we train them to do some of the basic cases, like appendix, hernia. Majority has been done by medical officer or registrar. So not necessarily every operation. When the surgeon starts to do appendix, then the workload will continue to increase. So I think only in urban area, the surgeon wants to do everything. In the private sector, for example, but not in the rural areas. So like, for example, GA, there's a policy that all general anesthesia must be given by anesthetists. This cannot be done because in rural areas, we do not have enough anesthetists. So what we do is that we train our assistant medical officer for 6 months or a year to give gas to GA. So once they are competent, then we send them to rural areas. So again, this is the practice we have been doing for since independence. I think we are still using the assistant medical officer to provide some of the services there. So what is more important is some of the complex surgery now, not only the 5 been named, but we identify and train them, eventually bring it to the district area. Now the cataract operation, we also have 2 buses going to the district hospital every 2 weeks, parked in the district hospital and provide cataract operation in the district hospital. So I think services now, we have to think out of the box the way we provide services. Rather than patient coming to our center, we are providing back to the community. And this is something that I think is creative ideas and innovation. We started 10 years ago, for example, medicine. Instead of coming to hospital and clinics to collect the medicine, now it can be delivered to you at home, for example. So that services has been available more than 10 years. So I think now we have to increase the number of cases. One example is hemodialysis. Can we have the hemodialysis at home? And in one of the area in Mulu Cave, for example, there is actually a native with a renal failure, but he can actually do a peritoneal dialysis there. So we provide some assistance without electricity, but we still can continue to do a peritoneal dialysis. So we have to basically look into some of the surgery, some of the services that we have, and we can actually bring the services to the community.
Fantastic. And it occurs to me that we're probably at as you speak, and we're probably at a unique moment in time. So many of the things that you've talked about would have been much more difficult several years ago, but the advances in communications, you mentioned kind of video calls and things like that are now part of daily life. You know, really, the let's say excuses for not decentralizing services and things are no longer there. So it really is a unique moment to put into practice maybe long-held ideas about providing surgical care in the community. So it's fascinating to hear your experience. Taking another question from the audience. You mentioned that the most important ministry is often the Ministry of Finance. It always comes back to money. What challenges and successes have you found in convincing the Ministry of Finance to prioritize health and surgery?
Well, when we talk about life and livelihood, I think, so pandemic certainly opened up, you know, the mindset of the Ministry of Finance. But it's not the amount of money, but how you optimize the resources that you have. So it really shows data and facts to convince them in terms of life being safe and procedures being done, the numbers of procedures, etc. So during the backlog, we convinced the Ministry of Finance for a certain amount of money that we can actually refer some of the cases to the private hospital, but at a negotiated pricing. So because the volume of cases in the public sector, COVID cases comes to our public hospital, and we need to refer the non-COVID cases to the private hospital to make room for the COVID patients. And the funding is available, and we send the cases to the private hospital. And private hospital charging a very minimum in terms of negotiate the pricing with them, and we can actually decongest some hospital. Then we discuss in terms of to provide weekend or Saturday and Sunday lists. Operating theaters are not being utilized during the weekends. So we start to utilize the weekend from 8 to 5, for example, and the Ministry of Health will pay them per hour because this is out of the normal services. And so these are some of the initiatives, then we can clear the backlog. So from 57,000 cases in September, and now we managed to clear, we only have 30,000 left. So we continue within a short period of time. So we hope that in another 6 months, we can clear the cases. So these are the initiatives, and hire the more specialists, for example, or staff. Some of our retired nurses, retired personnel, Ministry of Health allowed us to have a short contract with them, bring them back to our service to provide care to our patients, surgery, and etc. So I think these are some initiatives now. We also have the field hospital, as I shown to you in Cox's Bazar. The Ministry of Finance provide us funds to buy more field hospitals, and we can actually set up the field hospital in the nearer to the community. So these are some of the initiatives that we have done, and we hope that by working closely with other ministries, this is the beginning. So we hope that we can improve the care and services to our patients in the rural areas.
Great. And just coming back again to the medical officers and let's say the non-specialist cadres delivering anesthesia care as well. Something that we in RCSI have found when working with partners, particularly in sub-Saharan Africa, is that exposing medical officers to more basic surgical training, expanded basic surgical training, had a unexpected benefit in that we found a few years later, many of those had actually enrolled in surgical training, which wasn't necessarily the purpose of the program, but it was an unexpected benefit. Do you feel that this additional training and these additional responsibilities that are being given to so-called lower or mid-level cadres, is that encouraging? Is there a career progression path, and would you encourage people to follow it?
Yes, in terms of the policy, when they go to Borneo, for example, in Sabah and Sarawak, we give them the priority when they are qualified to apply for the local training program or in postgraduate. That's number one. Second is that we give them promotion, faster promotion in the rural areas. And third is that, in terms of the knowledge, CME, etc. So now with the communication, they can access to information. Those days you're going to rural areas, there's no library and etc. Today they can actually, for example, search the website and then contact the specialist hospital to provide information, advice, and etc. So I think the lesson here is that using technology, we can, wherever you are, actually we can reach out to the population and also the trainees. So they are not left behind. So we identify them. Once they have served, for example, 3 years in the rural areas, we give them the priority as compared to the candidates from the urban area. So, and they get more experience. I can see that my specialists, in terms of my medical officer that works in the rural areas, they have a hands-on experience, they are more confident, they are more matured in decision-making as compared to those trained in the urban area. Because there are so many layers, specialists, junior specialists, and before registrar, before they reach the medical officer. So I always tell them, if you want hands-on, it's better for you to get out in the rural areas and gain the experience. But you have to be under someone, in the primary hospital, for example, a specialist that monitor your performance and guide you in the rural areas. So you are not lost in the rural areas, but you are in the system. And hopefully we can actually give them the opportunity, and eventually most of them becomes a good surgeons in time to come.
Fantastic. Just a couple more questions. I'd keep you here all day if I could, but we don't want to impinge on your time. So you mentioned obviously medical officers getting a greater breadth of experience in the rural areas. What has been the Malaysian experience in retaining staff in rural areas? In some parts of the world, there's a high degree of turnover. Can I ask what the experience has been there, and are there any particular strategies to retain medical staff in rural areas?
Yeah, it's difficult to convince our medical officer to go to the rural areas. But, those days, if you have good connection, you stay in the urban area. You have no connection, you one-way ticket to the rural areas. So we have changed that. So if you have served 2 years in the urban area, housemanship, for example, then you have to get out of the urban area to the rural areas. Those who have served in the rural areas after 2 years, they apply, we give them the priority. So it's mainly like a rotation. It's not one-way ticket until you resign, for example. So we make it a concept rotation. We give more, give them priority for promotion. And we make sure that when they apply for postgraduate education, they will be given a priority. So these are some of the improvement that we have set. And now with the technology and flight, for example, in Tawau is quite probably the most remote area, but now we can access in terms of the flight, and those days is difficult. So I think now with technology and the facilities that we have, and if we manage to upgrade the facilities, we also try to have visiting specialists from the peninsula visiting to the rural areas. I think this is something that encourage and inspire them. And recently we have this fellowship with the Royal College of Surgeons Edinburgh, because they have two fellowship from that, and they will spend time in Borneo for 2 weeks, for example, and this will expose them to what we are doing. So I think the incentive and the perks that we can encourage some of our doctors to stay and to provide the services there. Once they are there, then they feel that it's very rewarding for them to gain the experience, but not for long, but because they have to continue their postgraduate education. So now we are trying our best to make this as part of the rotation and giving them the perks as well as the priority.
Great. That seems like you struck a really nice balance between, enabling personal progression and people to make their own life choices, while on the other hand providing services to your people. We're coming up to time, so just one final question. You mentioned just a moment ago, indeed, the college surgeons in Edinburgh. Many of the people joining our event here today, myself included, will be from higher income countries. Is there a role or what may be the ask, let's say, from Malaysia and indeed countries in the WHO Western Pacific region, the ASEAN region? What may be the role for high-income country institutions in supporting the initiatives?
Well, we are starting now in Malaysia. We are looking at local before we move to regional and global. So if we can actually utilize the concept of global surgery now, and we get the resources for public and private locally. So next is actually, can we use it for a hub, WHO hub at regional level, which means some of the services that we can provide to other countries. Likewise, then we open it up to high income countries to come to Malaysia to have practice. We have mooted the idea of border hospital, whereby, for example, in North Borneo, we have issues with regards to the undocumented migrants from Philippines and from Indonesia, and they come to our hospital because of human rights and etc. So we still provide services to them, but they come in a very advanced stage. Whether it's obstetric or even treatment for surgery and etc. So if we can actually set up a border hospital, and the border hospital will be run by Ministry of Health and also other ministries from other countries, or from NGOs, run by NGOs, and this will help in terms of to improve the quality care to the undocumented migrants. I think this is one idea, clinic as well as hospital, and we welcome those from high-income countries to come and serve in the Ministry of Health. And if we can start the regional or global engagement and collaboration, whereby surgeons from overseas can come to Malaysia. For example, you can learn some of the surgery, hernia under local anesthesia. I used to do thyroid under local anesthesia. So these are the technique has been forgotten, and you can do it in a district hospital. And I mean, the cases that we see, huge goiters, for example, my biggest goiters is 2.6 kilograms, for example. So these are something that you don't see in the West, but in the East, you still have these challenges of, the extreme of cases. So I think if we can enhance that collaboration to provide fellowship, for example, coming to Malaysia, coming to Africa, and I'm sure some of my friends from Australia providing services in Africa as well. So for a short period of time, maybe 3 months, maybe 6 months, this will be a good exchange and to drive knowledge and also to provide services.
Thank you. I think your call to action there has been heard loud and clear by our attendees here today. Tan Sri Dr. Hisham Abdullah, it has been an absolute pleasure discussing with you today. Thank you so much for taking the time to share your experience with us. Thank you for that, and I'll hand over to Professor Markshire.
Thank you.
Thank you, Dr. Hisham. Let me echo those thanks. That was an amazing presentation, and thank you for answering all the questions that we threw at you for the last half hour. I appreciate you being here. We're going to move on to the next section in our program. Very often in the global surgery conversation, you'll see It's still me. Okay, sorry, I just got muted. Let's start again. So very often in the global surgery conversation, you'll see nurses and anesthesiologists and surgeons, policy folks. We talk to each other, and often the voice of the patient is sidelined. And today will be a lot of nurses and anesthesiologists and surgeons speaking to each other. But our hope today is that we're able to bring the voice of the patient and the effects that surgery has on patients to the fore. We'd like to start that. The Institute of Global Surgery itself is built on a vision that has four pillars: pillars of equity, of collaboration, of evidence generation, and finally of patient-centeredness. So for the next section, I want to invite two of our PhD students here at the Institute of Global Surgery to discuss what patient-centeredness means in the global surgery space. And let me start with Selena Flox-Monahan. Selena comes to us from Florida. She has a Master of Public Health with a concentration in global health practice from the University of South Florida. And she earned her BSc degree in International Affairs from Florida State University. She's in her second year of her PhD program. And I will turn it over to you, Selena.
Great, thank you, Professor Scheim. I'm just sharing my slides. Of course, will be an issue. Lovely. So, as Professor Scheim said, I am a second-year PhD student here at RCSI via a Fulbright scholarship. And the heart of what my work is at RCSI and at the Institute of Global Surgery is putting this focus into practice of the principles of patient-centeredness to a pediatric surgery population in Malawi, and understanding the impacts of how each patient's journey to care and the interactions that they have with care providers impacts their long-term health outcomes. And so I want to start by thinking of how we think of patient-centeredness in a pediatric context. So our general definition of patient-centered care is this mutually respected relationship between the patient and the provider in a way which addresses both of their perspectives and their desired outcomes when they make these healthcare decisions. When we think about this for pediatrics, we have to consider all of those in the picture, which includes the family caregivers of the patients. This is probably the most important person. And when we want to apply PCC to pediatric patients and their families, we have to include the cultural values, the social values, the educational level, the social impact that their decisions will make, and how we approach informed consent to cater towards these groups. And most importantly, we have to address this gap between what patients want and then what the providers think that the patients want. In healthcare settings, we tend, especially when decisions are made quite quickly, the tendency is to think of the patient's needs at this very surface level. And these are the things that are more obvious. We know that patients want to see a provider quickly. We know that they want to have relief for their pain, and we know they want to be able to afford this treatment. Again, these are things that the providers can see and infer and assume in a quick and reasonable timeline. Similarly, when it comes to health outcomes from especially surgery, the focus is on biomarkers, things like, did the wound heal? Was there a great rehabilitation time? How long did it take for the patient to walk? Recovery time in general. And again, I would call these healthcare provider-centered desired outcomes. But we know that patients actually need and want much more to achieve their own desired outcomes. And so why should we care? And we know that there's this linkage between a high patient satisfaction, and this is from patient-reported outcomes, and lower mortality and morbidity and readmission rates. When we shift to consider the patient's experiences rather than just the outcomes and a more all-inclusive approach, we see particular gaps in the level of care given versus the level of care that patients actually desired to be given. And importantly, we need to place an emphasis on respecting patient values, which function as a filter through which patients can interpret their clinical data and how they make treatment choices. And in this large part, how this influences their desired outcomes, their healing time. The patient themselves is in charge of how long it takes for them to get better. And when we think about this within pediatrics, this is especially important for long-term health success. A child's life is much longer than an older patient's life. So in low and middle income pediatric surgery settings, most of this hasn't really been addressed. We tend to believe that in these settings, access to care is the only important and valued thing, and we overlook the quality of that access to care. Most of what has been researched is regarding patient and family-centered care in high-income settings, mostly in the United States and Canada. And there is a gap in how we know how to include values and expectations in surgical care services, particularly in LMICs. And while the principles of patient-centered care are the same, we do have to take into consideration the context and setting, which are vital to how we approach these. Patient-centeredness means something completely different in a pediatric hospital in Dublin than it does in a surgery center in Malawi. It changes based on your community, the setting, the procedures, emergency versus non-emergency surgery, so on and so forth. So my work here with the IGS aims to address two very important questions. What do pediatric patients and their families want and expect from their experiences in seeking surgical care in Malawi? And then what do they experience and how do these experiences affect their decisions and their outcomes? All of this work is supported by the IGS and the IGS network and the connections that the IGS has already built. This is a qualitative study which aims to understand the perspectives from both surgical care providers and from the patients. So initially, we intend to connect with families of pediatric surgery patients for elective surgeries only at a pediatric surgery specialty care center in Blantyre, Malawi. And we intend to have conversations about what did your journey from home to hospital look like? What were your values and expectations when you were seeking treatment for your child? How were those values met or unmet? How did those experiences affect you? And how did these experiences maybe affect people who didn't end up seeking care? You know, if you knew someone who was going through the same process as you, but they're not there at the surgery center with you. And this is to truly get at the heart of what pediatric surgery patients want and what their families want from their experiences. So after we interview the patient and families, we intend to have this conversation, the same conversation with the providers and the provider network of pediatric surgical care in Malawi. So not only surgeons, but also the nurses and the trainees in the system to gain an understanding of how they view the quality of their system, how they view their patient interactions, what they understand as the values of their patients, and how what they understand may differ from what patients and families have voiced as their values and expectations. And then eventually, we intend to look at the feasibility of making informed quality of care improvements. So, while the importance of listening to and acknowledging the patient stories and the provider stories is valuable and is the desired result of my work, there's also further potential for a long-term impact. The Malawi Health Sector Strategy Plan for 2015 through 2022 prioritizes quality of care improvements for the Malawian healthcare system. And the information collected from this population and from these patients may lead to improvements. And further, there may be some sort of opportunity for incorporating and emphasizing soft skills training in surgical training education. And then also, it's just helpful to know and to address the challenges that we have of accessibility of care for this cultural and social context. And that is a summation of my work. Thank you.
Thank you, Selena. We will be taking questions for both presenters at the end. So I'm going to go straight to introducing Dr. Paul Okeni. Paul will be joining us from Uganda. Paul asked me to keep his introduction quite short. Paul is a surgeon and a fellow of COSEXA, the College of Surgeons of East, Central, and Southern Africa from Uganda. He is an international research scholar here at the RCSI Institute of Global Surgery. Paul, over to you.
Hi, good morning or good afternoon, good evening, wherever you are. Thanks, Professor Mark Schrein, for that kind introduction. Can we have the slides, please? Yeah, so my talk, my short talk will be about patient-centered surgical care, how to define it and how to measure it in the context of sub-Saharan Africa. And for feasibility and logistical reasons, we chose to zero down on Uganda. And my talk will be mainly on two issues. One is I'll look at a conceptual overview of patient-centered care, and then I will share with you what we found so far and the possible next steps. And after that, we'll open up for questions. Next slide, please. Briefly, by definition, it's quite difficult to get a global standardized definition for patient-centered care. I think it's because patient-centered care is a soft outcome. And like all soft outcomes, it's very difficult to get around them, especially for medically trained people. And so we'd call it a Latin construct with proxies that are used to understand it. However, there are various definitions that have been put forward. For example, the Institute of Medicine defined it in brief as care that is holistic and responsive to individual patients' needs. A patient-centered care is a strong and core element of quality of care. In fact, the WHO, in its publication in 2018 regarding quality health care, puts patient-centeredness as one of the three core elements of quality care. The other two being effectiveness and safety of care. And again, in one of the popular publications by Donald Derrick regarding the aim or the triple aim of care, patient experience or patient-centeredness comes out as one of the key elements of the triple aim of healthcare. Next slide, please. In this slide, I try to go through the different dimensions of patient-centered care. In other words, how people have tried to conceptualize patient-centered care. Nearly 98% of these studies are done in either Europe or North America, and almost none of them must be done in Africa or Sub-Saharan Africa. As you can see, there are different conceptualizations. For example, Mead and Bauer in 2002 had 5 specific dimensions for patient-centered care. That is the biopsychosocial profile, looking at the patient as a person, looking at the doctor as a person, a shared power and responsibility, and creating a therapeutic alliance between the patient and the clinician. In 1993, Gettys had a very important addition to all these dimensions, and that is access to care. Next slide, please. In this slide, I briefly try to show to you the different benefits of patient-centered care. It's difficult. The default setting is usually to ask someone, what do we gain by promoting this kind of philosophy of clinical care? Yes, there are soft benefits, what we call soft outcomes, but there are also hard outcomes or hard benefits. For example, this systematic reviews found that patient-centered care or a patient-centered philosophy of clinical care actually results in reduced mortality, it results in reduced length of stay, it results in increased adherence to medication. It results in surgery, for example, it results into reduced reoperation rate. So patient-centered care has got very tangible benefits to healthcare, to the health provider, and to the patients themselves. The only thing that we couldn't find a strong benefit was in terms of cost. That AFIL in 2020 couldn't find any significance of the effect of patient-centered care on cost. Next slide, please. So having looked at all those, most of the studies have been done either in Europe or North America, and the conceptualization of patient-centered care being a soft skill tends to vary with context. And we know that patient-centered care is important. And secondly, we cannot implement what we do not know, what we cannot define, and what we cannot measure. So we went on to see how do we solve this problem? And we asked ourselves a few questions. Next slide, please. So we asked ourselves three we thought were important questions. One was, what's the definition of patient-centered care in the context of sub-Saharan Africa? And the second was, what are the perceptions that dimensions of patient-centered care among surgical providers and hospitalized surgical patients in Uganda? Uganda being, our case study. And the third question was, in this population of surgical patients, how may patient-centered surgical care be measured? Next slide, please. And so the overall aim of all this was to explore the concept of patient-centered surgical care and propose and evaluate a measurement tool, for patient-centered care in a low-income setting. So the plan was to go through 3 studies, answering the 3 questions or 3 objectives. The first was the systematic review, which has been completed already. This is a qualitative evidence synthesis. It started in April last year. The second is a qualitative study. We'll do in-depth interviews on the population of interest with the surgical providers and surgical inpatients conducted in 4 regional hospitals. And we tend to use a hybrid model of thematic analysis. And the third will be two studies in one, or projects in one, and both of them quantitative. We use a survey methodology, and the population this time is strictly surgical inpatients, and we use 10 large hospitals within the country. Next slide, please. So studies 2 and 3 will start later on in the year. So here we share the findings from study 1. Next slide, please. So being a systematic review in the interest. So the review is registered in Prospero. We searched different databases, as you can see there, and we included qualitative studies conducted in English within hospitals in sub-Saharan Africa. So these are secondary and tertiary health centers. And for quality, methodological quality, we use the CASP tool for qualitative studies. And we use the framework synthesis methodology to carry out this study. Next slide, please. And our findings of our result, our search result, I have to say here that we were helped by Paul Murphy, who kind of helped us from the RCSI library. He helped us with the search engines here. And so we got over 3,700 articles, and of all this, we included 35. Now, of all the 35 studies that we included, 45% were in obstetrics or maternal and child health. And they were conducted in 10 countries within sub-Saharan Africa. However, only one was conducted within the surgical environment, that is either the surgical wards or the operating theater. And using the CAPS tool, they are all of good quality. Next slide, please. Now, in the interest of time, again, I've summarized here, trying to compare the conceptualization of patient-centered care, healthcare workers, that is doctors and nurses, versus patients. As you can see, the patient's idea of patient-centered care is more relational. So they look at things like privacy, confidentiality, empathy, and dignity. And communication comes out very, very strongly. One that came out very interesting was the navigation of the healthcare system, that patients most of the time get lost within the system, not because they do not want to access care, but it's just they want to access care, but there's no one to show them through. On the other side, the healthcare workers tended to, their conceptualization tended to be more structural. Things like staff shortage, staff welfare, the power imbalance and bureaucracy within the system, resource constraints, and poor care coordination that that they think affects patient-centered care. Yes, we have divided this into 2, but you believe me that some of these things are shared between the healthcare workers and the patients. For example, communication is thought to be important from the side of healthcare workers as well as from the patients. But this was just to emphasize, to show you where the emphasis was and the two different teams. Next slide, please. So having looked at that, we came up with what we thought was a framework for patient-centered care in sub-Saharan Africa. So there are 4 key issues: looking at the patient as person, access to care, integrated care, and communication. And on the right, there are sub-components of each of these, trying to explain what this meant. For example, the main difference between this and what we found in the literature was the focus on cultural sensitivity. When you look at patient as person, the focus on cultural sensitivity and the idea of shared decision-making. Most times, the studies reported patients, giving out their power of decision-making to the doctors or to the nurses, with the idea that the doctors actually have the power or have the knowledge to make decisions for them. Other things in access to care and integrated care, important things like navigation and referral systems created a difference between high-income and low-income countries. And of course, patient empowerment that came out very, very strongly. Next slide, please. So in conclusion, the conceptualization of patient-centered care generally is similar to other contexts. However, there are relative prominences of basic necessities of life, health system navigation, as we've talked about, and resource constraints. The resource constraints involves both medical equipment and staffing levels. In one of the studies, for example, there was concern that you've got only one, let's say one oxygen machine, and you've got 3 sick patients, and you have to use this on one sick patient. Then what happens if there are 2 sick patients? So the healthcare workers are in ethical dilemma, kind of. So they think that obviously that's not the patient-centered approach to care. And secondly, access to care is more than just infrastructure. The process of care at the health facility upon entry may actually be prohibitive. In the obstetrics and gynecological section, with mothers delivering on the floor and healthcare workers, because of a long shift, they are tired and beating up these mothers. Of course, there will be that kind of action and treatment will be prohibitive. So it reduces the number of people reporting or coming to the facility for delivery. And the third is that the evidence of patient-centered care among surgical patients was actually very, very scarce. In this study, review, we found only one study reporting this. And this was mainly in the OR as well. Next slide, please. So that's the end of my presentation. In a nutshell, there are similarities between the conceptualizations of patient-centered care in high-income and low-income countries, with the differences briefly that I pointed out. I thank my supervisors. I thank the Institute of Global Surgery for working with me and with the rest of the team in this. Thank you very much.
Thank you, Paul. Thank you, Selena, for these presentations. The Q&A box is open for questions for either one or both of our presenters. Let me start with a question for the both of you. And I suppose, Paul, I'll ask you to take this first and then Selena to follow. There are a whole bunch of different domains that you both have mentioned in your talks of patient-centeredness, patient-centered care. Do you find in your review of the literature and your work in this area that certain domains are overemphasized and certain domains are underemphasized? And specifically, what do you think is underemphasized in the patient-centered care discussion?
Yeah, thanks, Prof. There are quite a number of domains, as you say, that are spoken about. And the emphasis actually are contextual. They vary from context to context. As I said before, for example, the emphasis among patients is more relational. Okay, the relational aspects of patient-centered care, whereas among healthcare workers is more structural resource constraints. And when you look at the geographical differences, the emphasis, for example, in sub-Saharan Africa, so far, I'm not saying that's all of it, but so far, what we found has been many issues of access and affordability. Yeah, so you find because of poor road networks, sense of transport, because of low level of livelihood, the patients have got to either sell a piece of land or sell their cattle so that they can access care. That is very prohibitive. So in some studies, you find the focus, when you ask about patient-centered care, they think about access and funding. So a patient, for example, who has a tumor and has to undergo chemotherapy every so often or every so and so weeks, that's a lot of expense for the rest of their life. Whereas the emphasis from the high-income countries could be more geared towards softer issues, more relational, a characteristic of an empowered population, I would say.
Yeah, I would have to agree with Paul there. I think that especially in the settings that we're looking at, it's that access is the most important thing, and that, people are just most concerned about access, whether that's barriers to access as well, transportation barriers, financial barriers, those kinds of things. But the bigger picture here, and especially when we're considering PCC, is that the quality of that access is what's most important. And that's across the board, whether it's adult surgical patients, whether it's patients seeking HIV treatment, whether it's pediatric patients. It's the quality and the approaches that the providers and all of the healthcare staff have is not the priority when it comes to setting up these systems.
Thank you, both of you. There's a question here from the audience from Neve Keenan. Many thanks, Selena, for your excellent presentation, and Neve wishes you all the best for your PhD. You mentioned your study will include groups of current patients and families and their providers. Is there, however, a population of patients in Malawi who have not yet sought medical care for whatever reason? And would expanding your interviews to include some of these people provide additional information for your study?
Great, thanks, Neve, for the question. Yes, so there obviously is, two sets of patients. The patients that maybe just went to the dispensary or maybe just went to the regional hospital and didn't complete the entire referral process. And so while it's not necessarily planned within my PhD study, but we've talked about that having conversations with patients and their families who are there by sort of proxy, they can tell us about maybe patients and their families who did not complete it, or maybe they know someone, or maybe it's their neighbor or their neighbor's child that has the same condition, needs to take the same elective surgery, but didn't go through that process. So, and because it is qualitative and informal, we're hoping that just sort of comes up in the conversations, is that this is our journey and how we went through the process, but maybe we know someone who didn't go through the same process. So we're hoping that by talking to people who go and do seek the surgery can also give us some information about people who don't complete the process as well.
Thank you, Selena. Paul, let me ask you a question. In your reading so far, is there a difference, and what is the difference between patient satisfaction and patient-centered care?
Yeah, thanks, Prof. There's generally confusion between the difference between patient satisfaction and patient-centered care, and the way many or a few of the scholars tend to look at it is patient-centered care is a process measure, whereas patient satisfaction is an outcome measure. So measuring the two, patient satisfaction misses out a lot on what has actually happened during the process of receiving care. Whereas patient-centered care looks at all the nitty-gritties and all the different processes involved in delivering care. And that's the advantage that patient-centered care has over patient satisfaction. So the idea now is to move away from patient satisfaction to move to measuring patient-centered care, because patient satisfaction doesn't give you an answer as to why the satisfaction is low, for example, or why the satisfaction is high. Just gives you a global rating. Whereas patient-centered care, being a process measure, gives you all the different possible domains. And you can be able to judge and say, okay, there was a low score here, so probably we should improve on this, or something like that.
Thank you. I'm going to direct one other question to you, Paul. This comes from Professor Chris Lavi. He says, great presentation. Can I ask how you would respond to a patient who wants you, the physician, to make all the decisions?
Oh, thanks. Thanks, Prof. Chris. Yeah, I think most of the patients would want to get involved, that for sure. However, when it comes to making the decision, the final decision, they wouldn't want to take responsibility, and they'd want to shift that responsibility onto someone else. And the patient shying away from making that responsibility could mean one of two things. Either they are not empowered enough, and they are worried about the outcome of the procedure. So if, for example, if the procedure came out badly, then they don't want to take the blame. If the procedure came out nicely, then they want to make sure that their doctor, is praised, or he receives the praise for the good work done. So the way I would respond would be to, if I could, is to buy more time and give information. And that is why the problem is knowing how much and what kind of information to give to these people. Yeah, so I do not have a straight answer, but what I could say is it will be contextual, and I take it on a patient like this. And as a warning is that everything that needs is all good for them. And so it's a combination of both the professional understanding and as well as the patient's understanding. One of the great scholars of this kind of shared treatment decision-making is called Charles, I forgot his other name, but it's a paper published in 1997 regarding shared treatment decision-making. It tries to grade all these levels, and if you're interested, I could get the reference and send it over to you. But it helps to guide the clinician on what to do in such situations, because not every patient is the same, and they have different levels of understanding, either because of the socioeconomic background, because of the education level, or even because of the gravity or the severity of the illness. Most times, the more severe the illness, the more the patients want the doctor to take control, because they don't want to take responsibility for the outcome of the disease. And the less severe the illness, the more the patient thinks that they should take control, because they kind of have an idea of how the outcome might be. Thank you.
Thank you, Paul. I think we have time for one or two more questions. Selena, I'm going to direct this next question towards you. Your project takes on an additional level of complexity because you are looking at pediatric patient-centered care. How do you intend to try to tease out the difference between the child's preferences and the family or parents' preferences?
Oh, a very difficult question. I think in some ways they are the same, but then obviously in some ways they aren't. I think obviously, if you put yourself in the perspective of a child, the entire process is intimidating. You feel sick, you feel like, you don't have any control over what you're doing. But I think the language and the approaches that the physicians have to take into account is also how to talk to pediatric patients. And I think, if you're a pediatrician or pediatric surgery, you're well equipped with that. And I think, so I think, children's wants and needs are, who knows what they want, they want to feel better, I think, and obviously the parents have to think about the bigger picture of it. And so, I think there's a fine balance, and I think that it's tricky to interview children, and I think there's obviously ethical issues with interviewing children. And so I think that when it comes to decision making and processes of decision making, it's mostly the parents that we have to focus on for this specific population.
Great, thank you. We'll take one last question, and this comes from Daniel Bradley. It's to both of you. Daniel, thanks you both for your great presentations, and then asks about the setting itself. Have you found differences in the gap between what patients and providers think they want, whether you're looking at surgical NGOs compared to routine provision from local providers? Paul, you want to go first?
Yeah, I don't know whether I've understood the question correctly, but I'll try to give an answer. Yeah, of course, there are studies that have reported very obvious differences between what the patients want and what the healthcare providers are providing. And thirdly, what the NGOs are doing. There's a nice review by one of the researchers in Sub-Saharan Africa. It talks about the main issue of patient-centered care in the region is because most of the NGOs that come, the approach is more of a vertical, a vertical approach. So they leave out the patient completely, and they focus mainly on, on their outcomes. So a vertical approach, basically, it's the way that we know has always been done, as opposed to actually integrating the patient communities in their care. So much so that at the end of the tenure of the NGO or lifespan of the NGO, or when they leave, the community has not been strengthened. So their health care falls back to where they have been. So that kind of thing. So that's one area. The other area is, most of the times we health workers think that acquiring a new machine or acquiring a new equipment, for example, in these days, there's a lot of talk about laparoscopic surgery and endoscopy in many developing countries. Yes, it's a good idea, but it risks shifting the focus away from the patient. So we think that by restructuring our hospitals, rebuilding our hospitals, putting new structures, putting new equipment, we think that we're improving the quality of care. Yes, we're improving one aspect, but we're missing a very, very important aspect of quality, which is patient-centeredness. You can have all the access to care, all the infrastructure.
I think we may have lost Paul. Selena, did you want to add anything to what Paul was saying?
Yeah, I think, sorry if I am interrupting Paul, if he comes back in. I think my interpretation of the question is that if you have outside providers coming in to provide, mission trips or whatever it is to provide surgical care for a brief amount of time. But I think the difference in that and then the local providers and the in-country providers is resources. And I think people who come in, and if it's outside doctors, they have more resources and they have more availability, and their training may be different, and so they can provide this care, whereas the local system may be overwhelmed, and they can't place the same amount of emphasis on this quality of care and patient-centeredness. I think there's strengths and weaknesses to both things, but I don't think that's a fair comparison. And there is a gap, obviously, but I do think it's resources is the main thing, and sustainability of that care in general.
Thank you. It looks like we really have lost Paul altogether. So thank you to Paul and absentia, to Selena for some great presentations. We've come to our first break in the day. This break will be half an hour, so we will come back at 12:10 GMT, 8:10 a.m. Eastern time in the US. Again, stay logged into here. We're not going to different sessions, and we will signal you verbally about 2 minutes before we'll start the presentations. Again, thank you, Selena. Thank you, Paul, for these presentations. We'll see you in about half an hour.
Good afternoon and welcome back. My name is Chiara Pittalis. I'm a researcher in the Institute of Global Surgery, and I will be your host for the next session. During this session, we will have 4 presentations. Those are abstract presentations, and we will have a second session in the afternoon today, and that will be facilitated by Dr. Jakub Gajewski, our head of research. Before proceeding, I would like to take this opportunity to thank all of the applicants who submitted abstracts for this conference. We received many applications, but unfortunately, due to time constraints, we could only select 7. So we will have the first 4 now in this session, and then the other 3 later on. Another note for the day is that we will have the presentations first, and then we will have a few minutes at the end for question and answers. So the 4 presenters are here with us today. You're very welcome. I see you have your video on. Please keep your mic off for the moment. And let's start with the first presenter, Dr. Olorontoba Ogunfolaji from Nigeria. Dr. Ogunfolaji will be speaking about profiling African health journals. Just a few seconds, yeah.
Hello and good day. My name is Olorontoba Ogunfolaji, and I'll be presenting the abstract of our study titled Profiling African Health Journals, the Scope, PubMed Indexation, H-Index, Open Access Status, and Publication Fees. I am a member of the Association of Future African Neurosurgeons and a doctor at the 68th Nigerian Army Hospital, Lagos, Nigeria. Africa contributes to a small proportion of health research, just about 2%. The low research has been attributed to multiple factors, including the lack of health journals and the plethora of challenges faced by this sector, including financial challenges. This study aimed to map out African health journals using publicly available information on major databases. The authors searched the African Journals online library for health journals from its inception to October 17, 2021. And the search was majorly to find health journals. The data extracted included the journal name, the current issue date, the scope and specialty of the journals, and the journal publishing practices and standard star rating. Journal title abbreviations were searched for using Google search, and we used the abbreviations to search on PubMed. In addition, we searched the directory of open access journals to assert each journal's open access status. The authors searched the Scientific Journal Ranking database from inception to October 17, 2021, and we gathered metadata on health journals worldwide. Quantitative and qualitative data were described using summary descriptive analysis, and the odds of PubMed indexation and open access publication were computed. Bibliometric metadata were aggregated and compared using the Jamovi freeware version 2.0. 2 scenarios were explored: Africa versus the rest of the world versus individual regions. The African Journal Online had 173 health journals registered on its database, and most journals had headquarters in Nigeria, about 94 journals from our search. 24 journals were in South Africa and 10 were in Kenya. Those were the highest number of journals with headquarters within the continent. 100 of these journals were active, and by being active, we mean that they've been publishing consistently for at least the past 2 to 3 years. 57 journals had 1-star publishing practices and had 2-star ratings. However, the majority, 112, had no star rating at all. The journal scope spanned most aspects of health. Few health journals were PubMed indexed, while just about 22 were indexed on the Scientific Journal Ranking database. On average, African journals had lower total publications, total references, and H-index when compared to the rest of the world and to individual regions. From our study, we've concluded that the African Journals Online Library has the highest and is the largest single database of African health journals among the major bibliometric databases. Major legitimate African health journals do not meet rigorous editorial practices, and there's evidence that this might be due to limited access to resources. African health journals face unique challenges that require targeted interventions. This is a picture showing the key findings of our study. Thank you.
Thank you so much, Dr. Gumfolaji. That was very interesting and definitely an important issue. And the next presentation now is by Ms. Jonelise Lowe from South Africa. She will be presenting part of her PhD work on delays in accessing care for appendectomy in the Western Cape. Jonelise, sorry, I think you are on mute. We can see your presentation, but if you can kindly turn on your mic. Thank you.
Hi, sorry, my presentation is pre-recorded.
Sorry,
similar to the previous speaker.
We have it here. Just one moment. If you can bear with us, we'll share it now. Just a second. Sorry.
Okay.
A qualitative exploratory study was done, and the study sites included East River District Hospital, New Somerset, which is a regional hospital, Worcester, which is both a regional and a rural hospital, and Groote Schuur, which is a tertiary hospital. Surgeons employed at and post-appendectomy patients from 2019 were recruited for the study using purposive and convenient sampling, and data was collected using semi-structured interviews. An inductive approach and thematic analysis was used to analyze the data.
Sorry, just one moment.
Good afternoon. My name is Jonelise Lowe, and I'm a PhD candidate. The title of the study that I will be presenting today is Exploring the Perceptions and Experiences of Barriers to Accessing Appendectomy in the Western Cape, South Africa. Surgery is an important component of healthcare. 1/3 of the global burden of disease can be treated by surgery. Appendicitis is one of the most common emergency surgical conditions that affects people across the lifespan. The standard treatment is appendectomy, a surgical procedure during which the appendix is removed. The 3 delays framework can be used to study delays in accessing care for emergency conditions, including appendicitis. This framework categorizes delays into 3 stages. Firstly, the factors that affect the decision to seek care after the onset of symptoms. Then, the delay in reaching a healthcare facility, and then the delay in receiving care after the patient reaches the first healthcare facility. Acute appendicitis is a time-sensitive condition, and any delays in accessing care will lead to increased morbidity and mortality. Currently, there is limited evidence identifying barriers in accessing appendectomy in the Western Cape, South Africa. Therefore, the 3 delays framework will be used to identify and better understand the delays to accessing appendectomy within the province. The aim of my study is to assess access to appendectomy in the Western Cape by exploring the perceptions and experiences of barriers to accessing appendectomy at certain hospitals and recommendations on improving access to appendectomy within the healthcare system. A qualitative exploratory study was done, and the study sites included East River District Hospital, New Somerset, which is a regional hospital, Worcester, which is both a regional and a rural hospital, and Groote Schuur, which is a tertiary hospital. Surgeons employed at and post-appendectomy patients from 2019 were recruited for the study using purposive and convenient sampling, and data was collected using semi-structured interviews. An inductive approach and thematic analysis was used to analyze the data, while in vivo 12 software was used to manage the data. All data were de-identified prior to analysis. In the end, 4 surgeons and 7 of the 12 patients have been interviewed thus far. Patients and providers reported that patients will delay seeking care due to a lack of perceived severity of symptoms. Instead, they consume medication or home remedies and only seek help when they are severely ill. Patients will also delay seeking care if they have lost faith in the healthcare system due to previous bad experiences at a certain facility, or due to the idea that if you go to a certain facility, you never leave. In other words, you go there to die. It is clear from the study that people do not even consider requesting an ambulance for an emergency due to the lengthy response time. Ambulances may also have difficulty locating the patient. This is of particular importance in rural communities, as hospitals are located at least an hour apart, and the ambulances are usually hours away when the patient calls. Patients often have to rely on non-medical transport, which overcharge them to reach a medical facility. Therefore, patients will delay seeking care until they have the money to afford the private transportation. Long queues and waiting times at public healthcare facilities also leads to a delay in receiving care. Therefore, patients prefer to visit a private doctor first. However, this leads to a delay when they eventually need to go to a public facility and wait. Another important delay, which was reported by the surgeons, was the inability of some of the lower level facilities to diagnose appendicitis, as they lack the equipment or the staff are not skilled enough to do so. On the other hand, facilities that are able to diagnose appendicitis often have limited operating hours. Limited accessibility to emergency theatres was also reported by surgeons. This is because of limited staff to open more than 1 or 2 theatres and a large influx of trauma cases, especially on weekends. In fact, trauma can lead to the reprioritization of appendectomies. When asked what could be improved in the health system, patients reported a need to improve patient-provider communication and reducing the waiting time for care. Surgeons suggested that a criteria be created to ensure that suspected appendicitis patients are referred as quickly as possible. There is also a need for more beds and more staff to open up more emergency theatres. These findings are important given that 71% of South Africa's population uses the public healthcare system. Therefore, there is a large burden on the public ambulance services and medical facilities, which leads to long waiting times. In an audit performed by Kong et al. To quantify the delay for appendicitis patients at a hospital in KwaZulu-Natal, South Africa, they reported that there was a long delay between the onset of symptoms and seeking medical help. A review found that EMS response time is influenced by whether the EMS has GPS and the number and type of ambulances available. All these findings align to the findings of my study. Lower level facilities also have limited diagnostic capabilities and/or limited operating hours, which leads to the referral of the patient. A study performed in Pakistan that investigated the differences in outcomes of patients that present directly to the hospital and those who are referred from another facility showed that interfacility transfers led to a delay in receiving care. What do these findings mean for policy? I think that improved communication between the patient and healthcare provider needs to be established. Improved health education on appendicitis in communities is also needed because communities are more likely to seek care sooner when they know which symptoms to look out for. consider extending the operating hours of certain departments in a facility to reduce referrals. Ideally, however, the health system will benefit from appendectomies being performed at district-level hospitals, especially in rural areas. My study added new knowledge by identifying the barriers that lead to delays in accessing appendectomy in the Western Cape public health system. These delays will be minimized if patients know when to seek care, are able to affordably reach care, and receive timely care once they enter the healthcare system. These are lists of references that we use in this presentation. I would like to acknowledge the National Research Foundation for funding this study and thank each and every one of you for listening to my presentation.
Journalist, thank you so much. And sorry for the technical difficulties. This is the joy of virtual conferences, but I'm glad that everything works out okay at the end. And the next presenter now is Dr. Belen McNavarro and a research group. We have a pre-recorded presentation done by one of our collaborators, Kathleen O'Connor, but Dr. McNavarro is here with us today, so she will be joining us for the question and answer session later as well. And the presentation, while we wait for the video, is about the MetaPinas project implemented in the Philippines.
My name is Kathleen O'Connor, and I'm here representing the MetaPinas team from CEU, Cardinal Herrera University, the University of Pittsburgh Medical Center, and our collaborators in the Philippines, notably Dr. Consolacion Pastor. Our abstract is entitled, Implementing an mHealth-Based Patient and Nurse Education Program to Reduce Wound Infection in Rural Philippines. The Philippines is classified as a low to middle income country by World Bank and is currently experiencing rapid industrialization and economic development. All citizens of the Philippines are entitled to healthcare services through the government-run program PhilHealth, but resources and services are concentrated in urban areas. Like many developing nations, the Philippines experiences the triple burden of disease, characterized by persistence of infectious diseases such as pneumonia and tuberculosis, rise of non-communicable diseases like type 2 diabetes, and overall increases in injuries downstream of evolving global issues, such as climate change and motor vehicle congestion. The weight of this threefold burden falls on the rural poor, who have less access to healthcare services that PhilHealth might cover. Surgical services are particularly scarce, and there are few resources for preventative care. MetaPinas is an international collaborative surgical initiative led by Spanish surgeons and local collaborators. Following the 2018 MetaPinas intervention in the Philippines, 28.8% of the 164 patients who received operations developed surgical site infections, which is on the higher side of surgical site rates reported elsewhere. We specifically adjusted our approach for the 2019 surgical initiative to the Philippines to minimize surgical site infection incidents and also created an infrastructure to streamline follow-up for surgical site infection monitoring. We devised a threefold interventional model to address the unanticipated rate of surgical site infection in MetaPinas 2018. The first intervention was designed to increase patient knowledge of wound care management. Patients received personal instruction from members of the care team postoperatively about early signs of infection and best practices for maintaining sterility at the wound site. The next intervention was ensuring that patients from rural communities who might not have access to clean water or materials for dressing changes had supplies to sterilize their wound and change their dressing. The third intervention was a novel mobile health-based communication system between the MetaPinas surgeons and the local care team providing follow-up visits. This permitted task sharing with local providers and provided access to specialty services for rural communities for a longer period of time. The sites of intervention were Santa Maria Josefa Hospital in Iriga City and San Antonio de Padua Diocesan Hospital in Masbate. Types of operation performed were umbilical and inguinal hernia repairs, lumpectomies, and tumor resections. We adhered directly to WHO guidelines for sterility intraoperatively to minimize intraoperative contamination of the wound. This included strict hand hygiene and use of 2% alcoholic chlorhexane solution. This is a copy of the flyer associated with our first intervention, aimed at increasing knowledge about wound healing and recognizing early sites of infection. Notably, we emphasize watching for signs of infection and leaving suture lines alone. Because many patients presented with comorbid conditions such as diabetes, and we know that postoperative glycemic control is a predictor of surgical site infection, we also emphasize maintaining a balanced, high-fiber diet upon discharge. This diagram demonstrates the wound care supplies that were provided to patients upon discharge. The total cost to prepare each kit was just €3. Patients were encouraged to wash wounds with saline instead of well water and to keep their dressing fresh as their wound healed. Finally, our last infrastructure developing intervention was to establish connection between the local nursing care team and Metapinas surgeons through mobile health-based care, or mHealth. The care team communicated with progress photos at each follow-up visit over the 30-day follow-up period. The interface was password protected and healing progress was color codified so that patients who required further monitoring received more attention and an amoxicillin prescription. This interface was mobile phone accessible, which is notable because mobile phones are highly accessible in the Philippines, even among rural care teams. Thus, phones may present a future link from the specialized services in Philippine urban areas to people that need them in remote areas. Here is an example of how the communication interface appeared to care providers after the 30-day follow-up period. In the top row, a patient who underwent excision of a preauricular sebaceous cyst had persistent infection. On the far right are recommendations for follow-up, which includes continued assessment at the hospital. The lower row is a patient who healed without infection from a lipoma removal, hence the green codification. In Metapinas 2019, rates of surgical site infection decreased to 9.7%. This differs greatly from 28.8% just 1 year before and demonstrates the efficacy of our three-pronged intervention. Of the 187 patients who received operations, 14 were lost to follow-up. Some patients lived far away from hospitals where their operations took place. This opens up the potential for an mHealth-based follow-up with patient connection in the future, considering the prevalence of mobile phones in the Philippines. The success of the intervention was contingent on the cooperation and assistance and expertise of our local Filipino collaborators. Each part of the intervention may individually assist in preventing surgical site infection. First, wound care materials and education about the healing process allows patients from resource-poor settings to have access to sterile materials that they might not have otherwise. At €3, the discharge kit presents a cost-effective investment in infection prophylaxis and encourages patient agency in the healing process. Our communication interface between surgical staff and the nursing care team allowed for extended follow-up in remote areas. Globally, there has been an exponential increase in accessibility of mobile phone healthcare due to COVID-19. We plan to use a similar mobile health technology to communicate with local providers in future Metapinas projects. There is even great potential for mHealth services to expand beyond care providers to directly engage patients in resource-poor settings. Thank you for your attention. I am now happy to take questions.
Thank you again. And last but not least, we have John Whittaker, who will be speaking about a study in Malawi on healthcare utilizations and barriers to seeking care for injury patients in Karonga.
Hello, my name's John Whittaker, and on behalf of my co-authors, it's a great pleasure to be able to present our project on health system utilisation and barriers to seeking injury care in Karonga, northern Malawi. Now, many of you may be familiar with this slide, which demonstrates a WHO advocacy image showing that injuries are a substantial but relatively neglected global health burden. And injuries, in fact, cause more deaths each year than HIV, TB, and malaria all combined. Now, the Lancet Commission in Global Surgery did many things, one of which was to help popularise the 3 delays framework as a useful tool for evaluating the whole surgical ecosystem. The 3 delays framework helps to consider the system and the barriers driving delays to seeking care, to reaching the place of care, and then to receiving quality care at a facility. Now, we used the 3 delays framework to examine the existing injury care literature, and we discovered that most injury care research is facility-centric across low-income countries. And we need more healthcare seeking behaviour data post-injury to understand potential access barriers. So our study aimed to describe health system utilisation and barriers to seeking care following non-fatal injury in Karonga, Malawi. So our study was conducted in partnership with the Malawi Epidemiology and Intervention Research Unit, which has a health demographic surveillance site in Karonga, northern Malawi. Here, a population of over 40,000 have been under surveillance since 2002. Now, this setting is a rural lakeshore district with a subsistence economy with agriculture and fishing as the mainstay. Now, in terms of the health system, it's served by primary facilities consisting of government facilities, a military facility which civilians can also access, private for-profit providers, and then faith-based providers from the Christian Health Association of Malawi. In terms of secondary facilities, there are 2 potentially available. It's a government facility 7 kilometres to the north and a CHAM facility 40 kilometres to the south, although over difficult terrain. And there's also one of the 4 central hospitals in Mazuzu, which acts as the tertiary referral centre for this region, 150 kilometres south. Our study was a randomised community household survey. We used the existing WHO guidelines for conducting community surveys on injury and violence and adapted them to our needs. And we used adult household members as a proxy to answer questions on behalf of the household. We used a minimum injury severity of that which prevented usual activities for at least 1 day or required the individual to seek healthcare. We also developed additional questions based on a framework from our previous Delphi study describing barriers to seeking care. For injured people who sought care, we wanted to know the first and second location if applicable, the length of any facility stay, the satisfaction with the care quality received, and how long it took them to seek, reach and receive care. For all injured persons not seeking care, we wanted to establish all the reasons and the most important reason why not. And for all injured persons, we wanted to know whether or not they lost a job, if indeed they had one, and if anyone else lost days of normal activity in order to care for them. We classified injuries, as is common in the literature, into major or minor, with major injuries being those that led to 30 days of disability or more. Delays to receiving care were classified to those within the golden 1 hour and also the Lancet Commission guideline target of 2 hours. And for ethical considerations, all participants gave their fully informed consent to participate, and the study was approved by research ethics committees in both Malawi and the UK. And we also conducted community sensitisation meeting, where traditional heads within the community attending a meeting, we had an opportunity to explain the study and answer any questions, and those heads could then disseminate about the study to the community. So in terms of results, we had a good response to our survey of 82.7% of households, and we found 611 non-fatal injuries and 4 fatal injuries over the previous 12 months, which is an incidence of 6,900 per 100,000 population. About a quarter of those were major injuries, i.e. 30 days or more disability, and 3/4 of those injured sought medical care after the injury, with a fifth of those staying overnight at a facility, with a median length of stay of 2 days, although up to a month. 3/4 were either satisfied or very satisfied with the care they received. In terms of the epidemiology, we can see, as is typical in the case of injuries, it's predominantly young, predominantly male people suffered the injuries. An interesting phenomenon shown in our survey, as can be commonly seen in similar surveys, is that the incidence of major injuries was relatively stable over the prior 12 months. However, we can see that there was a relatively higher incidence of minor injuries in the period immediately prior to the survey, and also around the 12-month point, suggesting that people are more likely to remember more recent injuries and perhaps over-remember those that exceeded just over a year ago. Therefore, we conclude that the incidence of major injuries probably represents an accurate estimation, although we probably underestimate the true incidence of minor injuries in this population. In terms of health system utilisation and the impact according to injury severity, if you suffered a major injury that's associated with more likely to formally seek care, stay in a facility overnight, attend a second place of care, and also have other household members lose days to care for you. Now, most people did not have a job, and so there was no significant difference between major and minor injuries in losing a job. This sunburst diagram demonstrates the facilities that injured people attended first, and we can see the vast majority attended a primary facility initially, and indeed a good proportion then subsequently attended a primary facility as a second place of care, and very few people in this population went directly to secondary care following injury. This sunburst diagram further breaks that down in terms of provider type, and we can see in blue the government primaries was the most common location for people to initially seek care. However, of note is that faith-based and private providers were a substantial minority of the location that people sought care, both as a first and subsequent place of care. In terms of time to receiving care, about half of the population received care outside of both the Golden Hour and the Lancet Commission 2-hour target. And for those not seeking care at all, we can see the most common reason was that the injury was not serious enough, although other common reasons given were that the patient had other priorities or responsibilities, they found it too difficult to get transport, or indeed the family member responsible for decision making was not available at the time. And then in terms of the most important reasons given not for seeking care, again, the injury not being serious was most commonly the most important reason. However, other important reasons included being too difficult to get transport and those associated with the financial cost, and also a preference for traditional healers. So in conclusion, almost all the injured patients in this population attended a primary facility first following an injury. However, nevertheless, half of those still exceeded the Lancet Commission target of 2 hours to receive care at this facility following injury. Substantial minority of those injured in this population never sought care at all, and whilst most of these injuries were minor, we identified important health system access barriers to address. Thank you very much for listening.
Thank you again to John and to all the speakers. We covered quite a range of issues, I think, that directly or indirectly affect patient-centered care. So we started with some of the barriers that patients might face when accessing care, and also challenges that they might face once in a hospital, once receiving care. And then we had a presentation about some of the solutions, practical and concrete solutions that can be implemented to improve the care provided to patients. And finally, we also touch upon the importance of supporting research in the Global South. So a lot of food for thought for today. So I would like to open the floor to the audience now for questions. I see now in the portal that we already have a few. So if the presenters can all join and turn on their videos, please. The first question is by Professor Chris Lavi, and it is for Dr. Ogunfolaji. And Professor Lavi would like to know who gives the star ratings and the criteria in the journals. Sorry, Dr. Ogunfolaji, we cannot hear you. We can see the video, but there is something not right with the audio. No.
Perhaps you'd like to try just leaving the session and rejoining in case it's just kind of a connection issue. Would that be worth trying? Maybe we could move on to the next question and then come back to him. Would that be okay?
Yes, we'll give you a few minutes then, and we'll move on to the next question. So the next question is for Dr. Navarro, and is by Professor Max Schreim. The question is, was inter-rater reliability of the mHealth intervention assessed? And if so, what was done if two raters came to different conclusions about the wound?
So thank you for this interesting question. So yeah, what was done, we assessed not only the external aspect of the wound, we also assessed if there was systemic clinical manifestation like fever or malaise. And in case that there was an inter-observer difference, then I was the head of the project, so I decided.
Okay, that's fair enough.
I'm not sure if this is a very scientific approach, but you know, sometimes you need to take decisions, and we are all surgeons, so someone has to take the risk of the decisions.
Okay, thank you very much.
Thank you.
The next question is for journalist Law. And our audience is asking, how many participants, surgeons and patients, were involved in the qualitative aspect of your study?
Thank you for the question. So far, I've recruited or interviewed 4 surgeons, and 7 of my patients were included in this particular presentation, but these are only my preliminary results. I will be, in total, I should have at least 12 patient interviews and then 4 surgeon interviews.
Okay, thank you. And I have a question myself following up on this, and this is for you, journalists, but also for the other speakers. My experience as a researcher, I work in a few projects working with patients, and I find that sometimes it is a little bit tricky because patients, due to their medical condition or maybe the situation they are at the time in the hospital, or even things like age, if they're elderly or very young children, and many other factors, they can be in a vulnerable situation. Therefore, as researchers, it is important to have a particular set of skills to work in studies with patients. So my question to you and to the other speakers is, in your experience, what was the biggest challenge in conducting studies with patients? What advice would you give to other researchers in the audience today who might be willing or planning similar studies?
To answer your question, so most of my patients, fortunately, were 20 years and older. And my patients are post-appendectomy patients, so they did have the operation at least 2 or 3 years ago, so from 2019. But advice that I can give would be, I conducted all of my interviews in person. So building that rapport with the patient is very important. You will find that a lot of the participants are initially nervous, but if you approach it calmly and you reassure the patient and you give them time, you listen to them, I feel like it helps. So that's really all that I can say. My study was fortunately not very high risk, but I also assured them at the start that if they felt like terminating the interview at any point, they were more than welcome to do so. Yeah.
Yes, thank you. I had a similar experience. I think it's important to have to establish a good relationship with the patients, with the respondents, and have some humility, some respect, and establish a connection. And Dr. Mike Navarro, I see you have your hand raised.
I think this is a very challenging issue, because when working overall, in our case, we work outside of our country, in another country, and we absolutely need to respect the rules of the other country, not only the legislation, but also the social rules. So we have to work in the same way as we work in Spain or in the European community, in the European Union. So one of the issues that we implemented was also the signature and of the informed consent. The World Health Organization provides you several models of informed consent that you can adapt to the specific issues. And I think this is a right that that our patients in our country have. So we consider that we have to offer the same for patients in other countries.
Yes, those are all very valid points. And John, I see you have your hand raised as well.
Yeah, thank you.
For your insights.
My methodology was slightly different, so it was a survey methodology, and so I'm doing it in a country in a native tongue that's not my own. So a key part of that, using an established tool and then adapting it, is careful translation, and particularly how to deal with certain non-translatable concepts, both in terms of health system definitions that might not apply directly across in terms of what represents a health post, a health clinic, various different grades of referral, and also concepts that might not work in the other direction. So people wanted to describe this particular barrier of neighbours or others having preference in their priorities, and there's a particular Chitumbuka word for that we have to translate in a different way coming back. And then also careful piloting as well was very helpful, because things that then you think are clear and have been translated well in a sort of the research community might not translate well. So that opportunity to pilot and revise whether those concepts are being accurately captured is important.
Yeah, and in your case, John, as you said, your study is different because it's a survey. So how did you go about recruitment? Because it might be a bit difficult when working in rural areas. Yeah,
so we were using a partnership with an organisation that has a health demographic surveillance site. So they're established and sort of embedded within a population, have been for a long period of time, conducting various sorts of research. And so they've actually, the population in that sense is already mapped out. All the households are sort of known and codified. And so we just used a randomization to randomly select 20% of the households that were in that survey. So it was pure randomization, and then using the network of research assistants who essentially are known within the community. And so there's a degree of acceptance to doing this sort of study, although the risk was low. So having that partnership gets like the disadvantage of you've got a community that are used to research, which can work, as a bias in terms of response, but also is very helpful in some ways that leads to, explore this sort of concept.
Yeah, thank you. Yes, I think having a good network on the ground is definitely essential in conducting these type of studies. We have a few more minutes, so I'm just gonna try to see if Dr. Gonfolaji is back. Can you?
He is back, but I think his sound is still not working.
Still no sound. Okay, well, we can see.
Can I ask a question to John Elise?
Absolutely, yes, thank you.
So is it very pleased to see you using the 3 delays framework for helping shape your evaluation of the health system? I'm just wondering whether you thought of any other frameworks as well. See, the Lancet Commission helped to popularize that, and I'm just wondering, sort of, if you could expand on why you chose to use that way of looking at the health system. Thank you.
I have considered other frameworks, such as Van Almen, and then the WHO building blocks. Off the top of my, those are the ones that, because there are quite a few adaptations of the WHO building blocks. I decided to go with the 3 delays because at the center, at the Center for Global Surgery, where I'm based, we do quite a lot of work with this particular framework, and I've seen that it does work. It analyzes and categorizes the delays very nicely. And then also because it's recommended by the Lancet Commission and it's been adapted for emergency access assessment, basically. So yeah, that's why I've considered it, but because I'm not finished with my analyses yet, so I'm not tied to this framework. So I might just combine this framework with another one But yeah.
Yeah, thank you. And both of you are using the 3 delays framework, and it came up also in the conversation earlier on in the other sessions. So maybe one question as well would be, is there any particular area of the framework that in your experience should be prioritized in improving the quality of care for patients, or do they all have equal weight, at least from your preliminary research findings?
Well, I think, I mean, from my, we did a literature review on in injury care. There's a huge bias towards people doing studies that are facility centric, and there's a real neglect from the delay 1. So that could mean that delay 3 is more important and therefore more studied, or it could be because maybe that is healthcare professionals doing research in environments that they're comfortable with. Or because maybe it's easier to do research in that context. So I think there's a bit of an unknown, really. I think that's the main point that we try to make in the trip, that it's an unknown as to what extent the first delay and also to a degree the second delay are important. So, you know, we would encourage more consideration of it, and then thinking of the whole, and really studies that try to combine understanding and be able to compare across the two, because there's almost a bit of an ignorance, I think, of which one is more important, because we tend to focus studies really in the facility and therefore not necessarily have that knowledge in certain contexts.
I agree. So another one of my studies that I'm doing is actually a scoping review, which is looking at the delayed appendectomy within low and middle income countries. And when I tally the delays, to say, delay 1 and delay 3 almost had similar weightings, but again, it depends on the population that you're looking at, because in this particular study, my qualitative study, according to the patients, delay 1 was more pronounced, and according to the surgeons, delay 3 was more pronounced. But I think they are equally important. Delay 2 is not really reported. It's just what is commonly known with delays in EMS services. But yeah, financial challenges is a big one. And then the resources at the facility is a big one. So I think they're equally important.
Yeah, absolutely. And on your research as well, journalists, we have a question from the audience, so I'll stay with you. Will the participants, oh, sorry, no, I meant John. John, will the participants receive a dissemination of the findings, considering this can be an eye-opener for them in access and utilizing healthcare?
Yes, certainly that's the intention. So this is part of a broader scope of work within the PhD. So we've done that in partnership with Meru, who are embedded research organisation, and then also with the sort of the community and the health system leaders. And so health system leaders that are integral to the dissemination of that, as are Meru. And so yes, we want to try and ensure that we disseminate in an equitable way that all stakeholders can benefit from the results. So that's ongoing, and I guess this is part of dissemination. I plan to do much more. Yeah. Thank you.
Okay, and sorry again, John, one more question for you. What were the main types of injuries, and how many patients required surgery?
Thank you. So I didn't ask specifically about surgical intervention required, but so in terms of, one of the challenges as well is when you're using a tool, is how they classify things like mechanisms and what the criteria are, and also how they classify the types of injuries. So in terms of the question about mechanism, the most common was a fall, that was about 30%. Then it was being struck or hit by a person or object, which is quite a broad category of things that could be going on there in that mechanism. And again, that was about a quarter. Road traffic accident, probably better called road traffic collision, because it may or may not be an accident, was 20%. And then the most common type of injury, which again is in this tool is a slightly broad definition, was a cut, bite, or other open wound. And that was about half. And a sprain or strain was about a fifth. So hopefully that's helpful. But we didn't ask about surgical intervention specifically in this community study. I mean, one of the other slight challenges of injury research is about severity, and if you're doing that in a facility center, you know, in sort of high context, using databases, use injury severity scores or others that require a fair bit of anatomical detail, and simpler tools have been used where that sort of particularly injury severity can't be gleaned, for example, by CT scanning. But when you take that a step forward into the, or step back into the community, getting that detailed severity, so you know, using surrogates like the length of disability and the sort of the detail that you can get in terms of the anatomical injuries is quite difficult. So you have to decide, I guess, how specific you want to be and how broad you want to be in terms of getting that sort of detail. So again, I guess answering that original question, that's another decision you need to make in this type of research, where you want to have that trade-off.
Yes, absolutely. You cannot cover everything. And related actually to the post-discharge side of things, have you measured in your study whether there was an overall long-term impact on patient finances and employment? And did patients face significantly increased or decreased post-operative income change?
Sorry, was that question for me again?
Yeah.
I mean, we just looked really at this idea of losing job as the financial impact, but actually, in retrospect, that wasn't a good question because of the subsistence economy. Most people didn't have a job, so the sort of surrogate, again, seeing that there was an association between the longer length of disability and the impact of family care members losing time to care for them. So that was a sort of, I guess, socioeconomic impact. We weren't more detailed into economic analysis. So most people don't have a job, so that's not probably a good question in this context. But there was this idea of family losing productive time, and that was a consequence. So that did occur, and that was more common with more severe injuries.
Yeah, was there any difference in terms of employment that they had for those who did have, who did declare an employment?
Yeah, so I'll just get my slide up to give you the accurate number there. I mean, I think we only had 48 people who had jobs, and there's no significant difference. Yeah. So 23 people lost a job, 48 people kept a job, but no significant difference across injury type. So I guess that's a third of people who had a job lost it. So, but the numbers were small in total.
Mm-hmm. Okay, thank you. And I also have a question for Dr. Belen McNavarro. In terms of your presentation was particularly interesting because you provided some examples of practical solutions that can be implemented to improve the care of patients. And it sounded like these interventions are relatively low investment in terms of, let's say, just raising awareness about how to care for wounds, or simple supply kits, or improving communication between providers. So they are relatively simple interventions, but highly effective. So my question would be, how would you approach institutionalizing those solutions so that they can be sustained long-term after the end of the project?
Yeah, thank you for this question. I think it's very interesting when you make projects that you work together with the local community. Okay, so that, I mean, this is the key point, because we are going back. So we need really to train or to give sometimes only technical support for the. In our case, the nurses were highly skilled, so it was only a minimal support that we needed to give them, no, and to train them in order to have the same language in labeling the aspect of the wounds, no. I think the difficult part is how to continue with the project once you are back in your country again. So that's why we try to make a long-time intervention, and we went to the Philippines for the last 5 years. Okay, we only presented 2018 and 19, and we skipped after the COVID pandemic because the islands were closed to foreigners. You could not access the country, and now we want to go back and continue with the project. So you need really to organize a long-term project, and you need also to look after the required financial support. Okay, this is important.
Yeah, absolutely. Even the kit that from the presentation, it sounded like it's relatively cheap, €3, which might be cheap for us, but not necessarily for somebody from a low-income family. So was that subsidized by the project or by the hospitals?
No, we work part of the project. We have two parts. The US part, where I wanted to point out the really collaboration of Ms. O'Connor, Kathleen O'Connor. She helped us a lot with this abstract. And then we have the Spanish part. We're working at a university, and most of the supplies were donated by our students. Okay, so we made several activities in order to get the money, and many of our students helped us with small amounts. We always like to make projects where more people can help by giving small amounts of money, so that this is a project of the whole university, not of only one person.
Okay, so as you say, funding definitely is something that needs to be looked at long term. Yeah, and did you have any, so you said there was an interruption with the COVID-19 pandemic, so how has that affected operations?
We don't really know, because it is difficult. The contact is sometimes difficult, and this is also another issue when you work outside your country. So we know that the morbidity and the mortality of COVID has been very important in the Philippines due to the low resources of the population, but also to the low resources of the rural hospitals. Of course, you have also the large hospitals in Manila, where they probably have the same problems than in Europe, no? But our small hospitals, they have very, very few resources. So we are actually starting to work together with them.
Okay, thank you.
Thank you very much.
And we only have a few minutes left before moving on to the next session. So just to close this session, there is one question that is in a way following up from the previous session, and it's open to all of the speakers today. And the question is, what aspects of patient-centered care don't get the attention that they deserve in your opinion or in your experience? Does anybody want to volunteer?
Possibly understanding that we're reporting outcomes that are important to them.
Yeah. Journalists, in your experience, you're working closely with patients and providers. What do you think?
I don't know. I think perhaps EMS services needs a lot of work. It's a big delay. It causes a big delay because of patients who aren't able to afford private transportation, but they also can't rely on EMS services at the same time. And then EMS services also plays a big role with inter-facility transfers. This is especially relevant in rural areas where facilities are located at least an hour apart. And in most of my interviews, I kept getting the answer that EMS resources are spread too thin. There's a shortage of staff and vehicles. So I think that deserves attention. I think it would make a big difference already.
Absolutely. And
I agree, the distance to the places and the distance in the rural areas, this is a problem for the adequate healthcare of the patients.
Okay, thank you. We've come to the end of our session. Dr. Ogunfulaji, I am really sorry that we had those communication issues. As I say, this is the joy of working online. But I would like to invite you to, if you have access to the platform, to maybe try to answer that question on the question and answer box in the platform, if you have a few minutes, just for the benefit of the audience. And thank you so much to all of you for your presentations and your insights today. I would like to ask you to please turn off your mic and your video. And I would like to invite Dr. Alessandra Colainanni to join us now. If Dr. Colainanni could kindly turn on, here you go. You're very welcome today. I know you're joining from the United States and it's quite early there, so we appreciate your effort and your commitment. Before proceeding with your presentation, let me just give a few words of introduction about Dr. Colainanni. Dr. Colainanni is an assistant professor of head and neck surgery at Oregon Health and Science University in Portland in the United States. She attended the University of Cambridge as a Gates Cambridge Scholar and obtained an MPhil in the History and Philosophy of Science. Her thesis focused on intentionally ineffective CPR. Her academic interests are medical and surgical ethics, as well as narrative medicine. She's a writer of creative nonfiction, and her work has appeared in many prestigious journals, including the New York Times, the New Yorker Online, the Examine Life Journal, Hobart, the New England Journal of Medicine, and many, many others. Today, Dr. Colainanni, in her keynote lecture, will address thinking from the patient's perspective, issues of consent, ethics, medical missions, and balances of power in global surgery. So, Dr. Colainanni, you are very welcome. The floor is all yours.
Thank you so much. Can you hear me?
Yes, we can.
Excellent. Okay, and I will share my screen. All right, good morning, and thank you so much for having me today. My name is Alessandra Colainanni. I'm a head and neck surgeon in Portland, Oregon, and I also write quite a bit about medicine. And I'm just really honored to be speaking alongside such a prestigious and talented group of speakers and thinkers, and on a topic that's very dear to my heart. So thank you so much to the RCSI for inviting me to address you today. Today, I'd like to speak with you as a physician who writes about medicine and writes about patients, about the power of stories in medicine and about how a sense of narrative may help us in our quest to deliver patient-centered care in global surgery. I have no disclosures. Today, I want to focus on 3 questions. First, I'd like to link the concepts of storytelling and narrative with the work that we do every day as doctors. In so doing, I'll introduce the field of narrative medicine and its techniques to those of you who might not be as familiar with this relatively youthful field of study. Second, I'd like to explore how narrative medicine can help us in the pursuit of the goal of this conference to deliver patient-centered care and to care for the patient as a whole person, keeping in mind their unique experience, point of view, and history. And finally, I'd like to spend some time thinking about how patient-centered care might be even more difficult to provide in unfamiliar, transient, or intercultural contexts that we see in global surgery, and how narrative techniques might help. So first, what does narrative have to do with medicine? So to me, Dr. Paul Farmer, who's pictured here, represents a particularly personal and vivid illustration of the power of stories. And I want to acknowledge the deep loss that this community has gone through with his unexpected recent death. About 10 years ago, I was a post-university trying to figure out what I was going to do with my life and struggling a bit to answer that question. And a trusted mentor of mine gave me Tracy Kidder's best-selling book, Mountains Beyond Mountains. And I remember reading it and being absolutely floored with the story within. After Dr. Farmer died, I reached out to a friend of mine who had been going through similar issues about 10 years ago, and he also remembered getting that book. And I think it's not an overstatement to say that book played a big role in where both of us are today. At the end of our conversation, my friend said, you know, everyone focuses on Dr. Farmer and he did amazing work, but it might have been Tracy Kidder who changed everything by writing that book. And my point here is to say that stories are very powerful things. They can inspire and shape us. They can change our minds. They can render us forever altered. And stories about medicine and about global surgery are very essential for many reasons. They help us to earn the trust of patients, to earn the trust of their communities, to inspire others to pursue surgical training and teaching, and for promotional and philanthropic materials that allow us to continue the work that we do, and so on. And so the stories that we tell about global surgery matter. Stories are powerful things for better or worse. I think it bears elucidating in what ways they can be powerful. So at their best and when undertaken responsibly, stories can celebrate, mourn, amplify the voice of the voiceless, help us to process difficult material, advocate, inspire, reveal truths about ourselves to ourselves, and call us to action. But when undertaken unilaterally or recklessly, stories can reinforce existing power structures. They can reduce people to characters. They can disempower or betray people that are relying on us. They can be exploitative. They can misinform. They can be destructive or dismissive. So I think this is important because listening to patient stories and interpreting them is at the heart of much of what we do as physicians. I don't think it's particularly controversial to say that listening to, responding to, and telling stories is essential to what we do as physicians and healthcare workers. The first thing we do when we see a patient in the clinic or the emergency room is to take their history, meaning we try to understand why that patient has come to see us at this point in time. When we listen to our trainees present their assessment of a patient's story, ideally weaving it into a narrative that encompasses symptoms, diagnosis, and a proposed treatment plan. When we write our notes in the medical record, we're telling the story of a patient's trajectory, ideally towards restored health or towards a diagnosis or towards an ending. When we surgeons dictate an operative report, we're telling the story of what we did, how we did it, and what surprised us along the way. So understanding stories and perspective and point of view from a narrative standpoint is crucial to the work we do every day. Stories can also help us to process some of the things that we experience during our work with the suffering. We bear witness to life's tragedies, comedies, and ambiguities on a daily basis in the hospital and the clinic. And many of us turn to writing down those experiences to remember them, to process them, or to publicize them. Physician storytelling has become exquisitely prevalent during this pandemic. One of the editors of the perspective section in the New England Journal shared recently with me that when the pandemic started and really throughout the last 2 years, she's been receiving 2, 3, and 4 times as many submissions to her narrative section as she historically had. Physicians are sending in narrative pieces about how their lives and practices have been completely upended. So something about the act of writing can be illuminating and therapeutic to physicians and to people reading the work of physicians. And sharing these stories with each other makes us feel not so alone in what can sometimes be an isolating profession, and maybe helps us process some of the more difficult stories we encounter. So I've argued that stories and storytelling have been a part of the practice of medicine probably since the beginning of medicine itself. But narrative medicine as an academic discipline is a relatively recent phenomenon. So it was founded by the woman pictured here, Dr. Rita Sharon of Columbia University in the late 90s. Sharon is an internal medicine physician, and she found herself in the middle of her career at a bit of a loss. She felt that her patients were hungry for a different kind of connection with their doctors, and she felt the same hunger for a different kind of connection with her patients. And she had the somewhat radical thought that literature might have the answer, that if we as physicians spent time trying to understand where a patient's illness fit into their own life story and their sense of their own life story, we might be able to listen to them more effectively and ultimately treat them more holistically. So she pursued a degree in English literature midway through her medical career in an attempt to understand the power of story. She recognized that our natural skill to listen to stories may start to wane as we become more efficient clinicians. And she felt that a sense of narrative was not just helpful, but necessary to be a good clinician. And she encapsulates that in her 2011 essay, The Novelization of the Body. She says, and I quote, Doctors enter the lives of patients in times of great disruption. The narrative thread of an ordinary life is interrupted by illness or even the threat of illness. Doctors enter these complex narrative situations having to imagine what the situation must be like from the inside. To do so requires, in addition to imagination, a fluency as reader and receiver of the accounts of others. In the absence of such fluency, the doctor is hapless, unable to fathom what is in fact occurring in the life of the patient, the life beyond the confines of the organs. So she defines narrative medicine as medicine practice with narrative competence to recognize, absorb, interpret, and be moved by the stories of illness. One of her colleagues, Dr. Sayantani Dasgupta, pictured here, expanded on that definition. Narrative medicine is the clinical and scholarly movement to honor the central role of story in healthcare. Long before doctors had anything of use in our Black bags, what we had was the ability to show up and to listen, to stand witness to birth, death, illness, suffering, joy, and everything else that life has to offer. But over the years, as medicine has gained technological developments, we've lost that initial simple ability to witness another's story. And what my colleagues in narrative medicine and I are urging is not that we forget all of our wonderful life-saving technological know-how, but rather that we once again train clinicians to elicit, interpret, and act upon the stories of others, that we hold in equal stead multiple ways of knowing, the scientific and the storied, the informational and the relational. I think that surgeons are poised to naturally do this because of the high stakes territory in which we work, and the transformative potential for better or worse that surgery can play in the life story of an individual. An appreciation for a patient's sense of their own life story might help us to understand, for example, why two patients with identical recurrent laryngeal tumors may have totally different reactions to the prospect of a total laryngectomy, or why a patient who makes his living with his hands might balk at the risk profile of a complex tendon repair. In other words, narrative medicine encompasses the humanistic aspects of what we do as physicians and surgeons, and in understanding our patients as full people. Like any other academic discipline, narrative medicine relies on techniques, tools, and skills. In practice, these typically occur in a small group setting and can involve medical students, residents, hospital-based teams, and staff, really any combination of people that works together in the hospital or clinic. These small groups use close reading and listening, reflective writing and sharing of that writing, and a group discussion to consider narrative and to escape the problem-based or reductionist mindset that can dominate the daily work of medicine. A typical session might go something like this. So a facilitator leads a close reading of a short creative piece, like a prayer, a piece of poetry, a short bit of prose, a piece of visual art, or an excerpt from a story. Attendees are then encouraged to share their immediate impressions of the piece, like particular words or images that might have stood out to them or questions they might have had. Then attendees do what's called a free write, meaning that for 5 minutes, they just continuously write pen to paper, not a finished piece, but just a raw reflection based on an open-ended prompt that's loosely or closely related to the creative text. Attendees then pair off and each reads their response to the other, and they reflect back on one another's words. And then the group comes together as a whole and share their responses with the prompt and reflect as a larger group. Importantly, the writing that's done in these sessions is confidential, and the purpose of the writing is not to write something good or positive or publishable, but just to use the act of writing to generate further insight or thought on the basis of the close reading. This is something that psychoanalyst Hans Lowald writes about, the sensory motor act of writing, how writing enables the flow of thinking to acquire substance and therefore to be communicated to the self and to others. And this act of immersing oneself in a piece of art and then doing a short sensory motor task of writing about it shows some promise in being a meaningful event for clinicians in terms of the way they relate to themselves and the way they relate to their peers. So that's an overview of narrative medicine as a field, and I hope it's apparent that approaching a patient interaction with narrative in mind by necessity helps us to view the patient in a more holistic and more complete way. Any story we hear or tell starts with a point of view, and usually that point of view is our own. Usually our story is the dominant story that we experience on a daily basis. This is powerful, but can also be blinding. And narrative medicine and these techniques really force us to consider other points of view. The act of close reading and reflection can open the practitioner up, and the act of writing can reveal thoughts that may have been latent previously. I would argue that a truly patient-centered care care that centers the patient as a full individual requires an understanding of the patient's point of view. Rita Sharon goes one step further. She's the founder of narrative medicine that we heard about a few slides ago. And she says that the act of writing about a patient can itself be transformative and can enhance not only the patient-physician relationship, but also the act of diagnosis. And she does this in her clinical notes. So she writes a regular clinical note, but then often will write an essay about a patient, a new patient, incorporating a sense of narrative into the essay. And she feels this is helpful. As she writes in The Novelization of the Body, my writing is done in an effort to see it first, to behold the situation outside of the restricted frame of the medical clinic, and to use that knowledge to correct lacunae in my own visual practices and then in my clinical practices. Writing shifts my position on the parallax, enabling me to take up another view of the real than the one I am trained to see. Such corrected vision improves my own capacity to register what a patient conveys about her experience. When done with skill and care, these become powerful hypothesis-generating acts, enabling the writer to give expression to half-formed impression that can lead to clinically useful perceptions. So narrative medicine writing can enhance the therapeutic relationship and, in Sharon's view, actually change the way that the doctor diagnoses the patient. Narrative medicine writing can also be used to center the patient in a more concrete fashion. So for the past 10 years, the Veterans Administration in the US has been using a program called My Life, My Story to document the lived experience of veterans. And the basic idea here is that a veteran will be paired with a professional writer or journalist who's working on a volunteer basis to interview the veteran about his or her life. The resulting narrative that is written by the journalist is shared with the patient and read and edited by them. The final draft actually goes into the medical record and is accessible by any of the patient's medical team. And this program's been active for about a decade and has spawned similar programs at other hospitals, particularly in Boston. And patients who have participated in the story describe feeling more seen, feeling seen like a whole human being, and feeling better known by their medical team, which often is a longitudinal relationship. And narrative medicine can also be used as to center the patient by advocating for the patient. And these are just a few fairly recent examples of narrative medicine pieces telling the stories of their patients in order to advance a particular agenda on their behalf, advocating for improved rural health in the US, advocating for anti-racism, and other examples like it. So how do we bring this narrative medicine idea into a global surgery context? What might be particularly difficult, and what might be we particularly want to be aware of as we move forward in helping our patients to tell their stories and telling the stories of our patients? So I would argue that providing patient-centered care is more difficult in unfamiliar, transient, or intercultural contexts like the ones that we see in global surgery. So global surgery engagements are often high intensity and time limited. Practitioners and patients may not speak the same language and rely on interpreters, which can make deep connection difficult. And sometimes these engagements are ethically complex in terms of equipment availability, post-operative commitment, informed consent. There are power differentials at play in every medical interaction, but these may be more pronounced. And finally, language and cultural differences may present a barrier to patient-centered care. I think narrative techniques and kind of what we've heard about in the narrative medicine world may contribute to this discussion. I think narrative techniques can help us to contextualize, historicize, leave room for nuance. I think that narrative techniques can leave room for multiple interpretations, for example, of a piece of poetry. I think narrative techniques help us to honor others' experiences and help us to practice holding multiple points of view. Help us to consider authorial context and intention when we're reading a piece. I think narrative techniques can help us to actively address the savior narrative and encourage decolonialization of global health work. And ultimately, I think narrative techniques reduce the distance between the self and the other by considering stories in a holistic way. For those of you who might be interested in learning more about narrative medicine, I'm happy to share these resources, which include newsletters, journals, podcasts, as well as degree programs within Columbia University. I'm happy to get in contact with anyone regarding these if you're interested in learning more. There are also several free workshops for healthcare workers if you're interested in joining these. And I'm again happy to share the website with anybody who is interested. I want to leave you with a quote from Rebecca Solnit's essay about power, which appeared in her essay collection, Whose Story in This Is This, which was specifically addressing female writers. So she says, if power generates a cushion of obliviousness around it, those of us with power need to counter it. That means first treating people with respect, regardless of their status, not taking the invitation to disdain or ignore. It means if you have some power, and most of us have some in some contexts, even if we lack it in others, being aware of how your status may cut you off from what others know and may share among themselves. It means knowing that you do not know. A more radical response is to try to undo the inequality. It means being critical of the forces that create inequality and remembering that they create asymmetries of audibility and impact. The unexamined life is not worth living, as the aphorism goes, but perhaps an honorable and informed life requires examining others' lives, not just one's own. Perhaps we do not know ourselves until we know others. I think this quote really crystallizes why that goal might be linked to centering the patient. So I'll stop there and open it up for any questions. And again, I just want to say thank you so much. I'm truly honored to be here speaking with you today, and I'm happy to take any questions at this time.
Yes, Dr. Colainanni, thank you so much. It was such an interesting presentation and a lot of food for thought again. Just a reminder to the audience, please do post your questions on the platform so that I can read them loud. And I will give you a few minutes, and maybe let me start with a question myself. As you say, Dr. Colainanni, understanding patient stories and compassions are essential to meaningful interactions between providers and patients. So if we consider that surgeons are often very busy, they work under extreme pressure, they have a busy schedule. So how can they build some of these principles into their practice? How can they balance their workload with some of those principles that you've been explaining?
Yeah, I think that's an excellent question. That's one that I'm struggling with as I'm in my first year of attending practice myself. And what I would say is that centering the patient, I think, is less about time and more about intention. And I think that patients can tell when you're really listening to them. And I also think that, you know, taking the time to ask the name of the dog or what they did for work really actually doesn't take very long at all. So and I would also argue that making that kind of connection and having that deeper kind of relationship with the patient ultimately makes your work easier because establishing trust is really based on that kind of gestalt.
Yes, and we have a question from the audience related to this. It's from Professor Mark Schein. Dr. Colainanni, you have told many stories in your own writing, both of patients and providers. Is there one in particular that has particularly challenged your own dominant narratives?
Oh, that's a really good question. I wrote a story a few years ago about a patient who I took to the emergency or who I took to the operating room straight from the emergency room. He needed an awake tracheostomy. It was a very acute type of situation. And I wrote about it, and then I wanted to publish the piece. I had written it and workshopped it with my writing group, and I wanted to publish the piece, and I wanted to obtain the patient's permission to publish the piece because it was pretty identifiable. And I thought that I had written the story in a very respectful way, but as I was rereading my own words, imagining him reading them, I thought, oh my gosh, I would hate to read this about myself. And so that act of literally reading it from the perspective of the patient made me aware of some blind spots that I had thought sounded great, but in fact were probably a bit harsh.
Okay, and actually, if we bring this to an international perspective, because you touch upon this in your presentation, the culture and context matter. So can you elaborate a bit more about that? How do you think there is a difference in interactions or space for interaction, let's say, between patients and providers in different contexts and in different cultures, or even the way the interactions are perceived?
Yeah, absolutely. I think it's difficult for two people from the same community who share a language, who share a lot of background. I think it can be difficult for those two people to connect. And so when you add the complexities of a completely different worldview, or really kind of almost no shared understanding at all, I think that becomes much more difficult. And so I think that maybe plays into kind of like a sense of almost superficiality, if that makes sense. You hear a lot of kind of the same types of stories about global interactions, providing candy or providing, do you know what I mean? So I think it's difficult. I don't have a great answer for how to make it better. I think that will take time. And again, I think, one thing, as somebody brought up in the last panel, using the same standards of care for informed consent with every interaction that we have. And I think that applies to narrative medicine as well. So similarly, kind of treating everybody equally and like doing the work, even though it's harder.
Okay, yes, it's a difficult question. And I'm going to ask you another difficult question. And this is coming from me. I'm not a doctor, so I'm not an expert in this, but I read somewhere recently that compassion is important in healthcare. But at the same time, it can also be dangerous, because compassion and empathy the health workers have towards patients, it's important for their interactions, but can also lead to stress when there is too much compassion or when there is too much empathy, because the lines between professional and personal get blurred. So what do you think about this? Is there a right amount of compassion or a right amount of interaction, and when should we stop?
Oh, Chiara, you've like hit on the central thing that I like to think about and write about, and I have not solved that problem for myself or for anybody else. I think, when you're in medical school, you learn this idea of like detached concern. So the idea that you're, empathetic, but also objective. And I think that it's a spectrum, and I don't think that there's a perfect amount. And I think it may vary between patient and provider. I know some of my colleagues, I think are very self-protective, and so don't get super involved with their patients. And I think that's the way that they continue to thrive in their profession. And I have other colleagues who, are calling their patients at 8 p.m. and are really involved in their lives outside the hospital. And yeah, I think it can be dangerous, but I also think that it's a very exquisite and honorable danger.
Yes. And I'm just seeing now the question from the audience. There is actually a very similar questions related to this. This is from Neve Keenan. Could you speak a bit more on the link between narrative medicine and well-being among physicians and surgeons? In our own experience, creating time and space for connection improves job satisfaction and potentially reduces stress and burnout among doctors. So she's taking the other side of the discussion.
I think that is that's accurate. I think that particularly in the last 2 years, but really before that as well, being a physician, being a surgeon is a high stress environment, and it's something where you're kind of constantly forced to deny yourself things that you might need. So, from being in the operating room for 12 hours to coming back at 2:30 in the morning to take a flap back, you're kind of used to putting yourself second. And so I think one thing that narrative medicine, these small groups can do is to create a space for people to express emotions and to think about things that are not necessarily part of everyday medical care. And I think that's a form of self-care, at least for me. I'm not saying that it's going to be the golden ticket for everybody. But certainly for me, it's been helpful in processing some of the ethically difficult things that I've witnessed during training, and just kind of maintaining a connection to the creative life outside of medicine and trying to bring it within medicine. So I don't know if that answers the question, but yeah.
Yeah, no, I think so. And sorry, we have so many questions from the audience, but in terms of then teaching, education of medical practitioners, one question is, there is clear value in teaching narrative medicine as a skill for all medical trainees, but maybe isn't always included in the curriculum among the technical skills. How would you sell its value to educators?
So I think that's work that's being done right now. There's some pilot programs that have some reasonable data. They're not huge programs, but suggesting that it kind of reduces burnout, can improve empathy. There's a well-described kind of decline in empathy as medical students progress through their training. And this has been shown, at least in small groups, to help with that. And so I think that's part of it. But I also think that, at least within the US, this idea of narrative and humanities being an important part of medicine that maybe has been kind of put on the back burner for a while is gaining traction. And so I would point you to the ACGME. I think actually the ACGME website now has some resources on narrative medicine and incorporating the humanities into medical training, because this is an ongoing discussion.
Mm-hmm. Mm-hmm. Yes, and bringing this conversation again to an international perspective, again, this is a question from the audience. You mentioned narrative medicine countering the savior narrative, and this is important when we talk about medical missions or about global North and South relations among practitioners. So can you expand a little bit on that?
Yeah, so I think historically, and I'll probably maybe make some people angry, but hopefully not. I think historically we've really only heard one type of global surgery narrative or global health narrative, and it's been kind of the practitioner goes and saves people and then comes back home and feels really good about themselves. And I think that narrative is tired. And I think it's time to hear from other voices. And I think we're starting to hear from other voices. And I'm forgetting the name, and I initially had this as a slide, but there was a very popular, very beautiful article that was written in the British Medical Journal called How Not to Write About Global Health recently, and I'm totally forgetting the name of the person who wrote it, but it was actually based on one of the most popular essays to ever be published in the literary magazine Granta, called How Not to Write About Africa. And it's a satirical piece, just essentially calling out the savior complex and the savior narrative as being a very tired form of story. And so encouraging us to approach these stories with more nuance, more context, more historical, and more willingness to not be the hero, to use our voices to tell others stories.
Yes, yes.
Yes, it was Desmond Jimbom. Thank you so much, Barnabas Allende. Yes.
I've been posting it. Yes, yes.
Thank you.
And another question is about your own background as a medical student doing medical electives in a low resource setting. How do you think medical electives can be more balanced to be beneficial to patients rather than students?
Well, I think that I struggle, other than in a research context, I struggle to find justification for having medical students practice any kind of medicine in a low resource setting that they would not be able to practice in their home countries. I just from an ethical perspective, I don't think that that is justifiable. And so I think that really rethinking the nature of medical missions and rethinking the nature of student health trips. And I speak as somebody who went on one that was sponsored by my medical school, that in retrospect was not a good, sustainable or useful trip for anybody but the students involved. So I say this as somebody who has been a sinner in this regard. But yeah, I don't see the utility of having medical students perform any kind of practice that they would not be allowed to do in their home countries in a low resource or low income country.
But do you still think there is value in having those exchanges between Global North and Global South, or should they be maybe more balanced and being two-way exchanges maybe?
I think it should be two-way. Yes, Chiara, that's exactly right. I think it should go both ways. I think it should go both ways. And I think we need to really be critical and skeptical as we kind of address these issues moving forward. More critical and more skeptical than perhaps we have been in the past.
Yeah, and in my own experience, as I said, I'm not a doctor, but I remember we did a study. We were part of a project in Malawi, Zambia, Tanzania, working with a number of hospitals, and we interviewed a lot of clinicians there. And I remember one of the clinicians say that even for the local providers themselves, sometimes there is competition for doing procedures while they're training, because there are different cadres of providers. There are specialist surgeons and non-specialist surgeons, and somehow, I don't know if this is a rumor or if it's true, but the specialist surgeons are given the priority in the central hospitals in terms of training. Not really the priority, but they have more access, maybe. Mm-hmm. It. They have more access to practice and improve their skills, while the non-specialists have less time. So yes, it's interesting to think about, there is already maybe this dynamic locally, and how would there an international influence impact those dynamics? Maybe it's beneficial, maybe it's not. I don't have the answer, but definitely something to think about.
I think with surgery, there's a tendency, or maybe a propensity to think of things as very simple. You know, I'm just a dumb surgeon. I cut out the bad problem and then it's over. And I think in global surgery, first of all, I don't think that's true. I think surgery is very complicated, and I think the decision to go for surgery is a complex one, and it's made even more complex when you consider all of these other factors, such as, you know, just historically, we have to understand that the story doesn't start when we arrive, right? The story has been going on for long, and there's things that we will not understand unless we ask the right questions and are open to the answers.
Okay, thank you. Sorry, so many questions. We only have a few minutes left, so let me see. Let's pick maybe one more question. This is of a more practical nature. The question is, other research tools for telling a patient's story exist, such as photo voice, using images, photos, videos to tell a story. So how do you see the interface of these methods with narrative medicine?
Yeah, that's a great question. And I think narrative comes in many forms. And while the form that I have the most experience with is writing, certainly there are other forms that are equally, and if not more impactful. And I think that photojournalism, photo essay, video, documentary, all of these things are absolutely part of narrative medicine. I don't want to shortchange narrative medicine and say that it's only about writing about patients, because you're right, it's about telling a patient's story or interacting with a patient in an artistic way, and certainly photo and documentary are a part of that. And similarly, if I, were to write about or photograph a patient, you would obtain consent the same way that you would obtain consent for a procedure. And so I think that also applies here.
Yeah, that's a good answer. And I'm just wondering, have you ever explored the patient's perspective on narrative medicine? Have you ever asked them if they enjoy this type of approach or study this?
Yeah, so I've done that in a few situations, usually in the setting of having written an essay about a patient and then sharing it with the patient prior to asking their permission for publication. And it's always a bit nerve-wracking when you've written something about someone, because you know, you never want to cause offense, but you also want to tell a true story. And so there have been several occasions where I've been like, oh man, this person is really going to hate what I've written, or they're going to be angry, or it's going to destroy the relationship. And in every case, and I don't know if I've just been lucky, or if it's something about the doctor taking some time to think about your case in a different way than in the clinic, each time it has only brought me closer to that particular patient. And so I'm a believer that patients are happy when you are moved by their stories, or when you are moved by them, or when you think about them after they leave the room or after you leave the room. And so I think that it only adds, it doesn't subtract.
Mm-hmm. Yeah, absolutely. And just a curiosity, how do you even explain these situations? Because you're talking about consent and informed consent. So how do you even approach that, again, for the benefit of the audience?
Yeah, absolutely. So anytime I've written something about a patient that I'm thinking about, hey, I'd maybe like to publish this, I'll get in contact with that patient and I'll say, listen, I was thinking a lot about what you said when we were speaking, and actually I was thinking a lot about it when I went home. And sometimes when I'm thinking about things, I write them down just to sort of understand a little bit better what I'm processing. And I've written this piece about you, and I'd love for you to read it if you're comfortable with that. And then we'll go from there. So I don't start with the ask of like, can I publish this thing that I wrote about you? Because the prospect of reading a piece about yourself versus the prospect of like the entire public reading the piece about you is a very different thing. Yeah, I've found that that approach works well in each instance in which I've tried it. And then there are also times when you can't obtain the patient's permission. So for example, if you don't remember their name because it was a very quick interaction, or if the patient is deceased, or if it was an interaction from medical school 10 years ago where there's just no way of getting in touch. And in those situations, I think the burden is on the physician to make the patient unidentifiable even to themselves. It's a little sticky. I mean, it's not cut and dry. And I think that writing about patients, there's always a power imbalance, because if you are still their doctor, then there is the possibility of, you know, they might think that you would treat them differently if they said no. And so I think it's sticky. It's not comfortable, but it shouldn't be. So that's kind of where I'm at on it at the moment.
Yeah. And as you say, the dialogue and open communication is probably very important in this process to make sure that they understand what they're signed up to, and they're fully aware. In my own experience, I haven't worked in this particular area, but again, as I said, I work with patients. Sometimes they're very interested in also receiving the output, mm-hmm. the final product. They really want to see it. So I don't think that opportunity of continuing the dialogue after the piece of research is done, or after the particular intervention is done, is taken advantage of enough, because patients enjoy the interaction. Not always, but they usually do. So I'm just checking. I don't think... sorry, we have one last question. So how can clinicians support patients telling their own stories?
Oh, that's a great question. I mean, I think that there's something to be said for therapeutic listening. And then I think there's something to be said, and this won't apply to every physician, but I think that many physicians feel a pull to advocacy work. And so I think that part of kind of writing the historical power differentials and power imbalances is using whatever power we have to help our patients tell their stories, if that's something that they want and would derive benefit from. And so, I've seen a few really nicely done narrative medicine pieces recently, kind of on the theme of advocacy, using a patient story with their permission to advance a particular agenda on behalf of that patient. And I think that also is a little bit tricky. Like, you really have to know that the patient is okay with you sharing their story. But I also think that reading about some inequality is very different than reading a personal account of that inequality action. And so I think that that's the power of narrative. That's the power of story. People like naturally want to listen to that kind of story. They don't necessarily have the bandwidth to listen to just kind of statistics about inequality. So bringing that story into focus on behalf of the patient, I think can be a really powerful tool and something that narrative medicine can help with.
Yes, yes. So you think that could be used as an advocacy tool as well?
I do.
Okay, thank you. So many insights. Thank you so much. We have come towards the end of our session. So I just want to remind the audience that we will have a break now. Let me just double check. We will be back at 2:20. So please, you can stay online, stay in the session, and just come back at 2:20. And Alessandra, if I may, thank you so much for your presentation. It was very insightful and thought-provoking. So I'm looking forward to reading your work and continuing this conversation.
Thank you so much for having me. And again, thank you for all the wonderful questions. It's not always that narrative medicine gets this kind of response. And so I'm just really thrilled to be here with you.
Thank you.
Hello, everyone. My name is Ines Peric. I am Education Program Officer at the RCSI Institute of Global Surgery. I'm here to welcome you to the afternoon part of our session of our Dublin meeting. Some of you have joined us here in person today. It is lovely to have you, and most of you are online, and we are very privileged that you joined us today. I hope you have been enjoying the meeting so far, all the wonderful speakers and their insights on the patient-centered global surgery. Before I introduce you to our next keynote speaker, just a reminder to feel free to write any questions you might have in the Q&A box during the talk. You do not have to wait till the end. So our next keynote speaker is Professor Agnes Binagwaho, the Vice-Chancellor and co-founder of the University of Global Health Equity, an initiative of Partners in Health based in Rwanda, which focuses on changing how healthcare is delivered around the world by training global health professionals who strive to deliver more equitable, quality health services for all. Previously, she has provided clinical care in the public sector and has served the Rwandan health sector in high-level government positions. First as the Executive Secretary of Rwanda's National AIDS Control Commission, then as Permanent Secretary of the Ministry of Health, and lastly as Minister of Health for 5 years. She's a professor of pediatrics at the University of Global Health Equity, a senior lecturer in the Department of Global Health and Social Medicine at Harvard Medical School, and an adjunct clinical professor of pediatrics at Dartmouth's Geisel School of Medicine. Professor Binagwaho is a member of the US National Academy of Medicine and the World Academy of Sciences and a fellow of the African Academy of Sciences. She was named among the 100 most influential African women for 2020 and 2021. In her keynote lecture, Professor Binagwaho will address what patient-centered global surgery means to her as a pediatrician, a former policymaker, as a Rwandan, and as the Vice-Chancellor and co-founder of University of Global Health Equity, Educating the Next Generation. I'm very excited to hear Professor Binagwaho speak. So Professor Binagwaho, the floor is yours. I think you are on mute.
Exactly. I was disciplined and muted myself to listen to you, and I forgot to unmute myself. So thank you very much. I'm very honored to be with you all. And I tell you, for the time being, I'm in Washington, where I went to the US for the memorial of our late and beloved Paul Farmer, who co-founded the university with me. So I tell all of you good morning, but also good afternoon for all of you who are elsewhere in the world, and good evening if needed. So as I told you, it's a pleasure for me to be joining you during the Dublin meeting in patient-centered global surgery that you organize at the Institute of Global Surgery. And today I would like to talk to you about what availing surgical care to all should look like, with a specific focus on the part of the world when I'm working on daily basis in sub-Saharan Africa. Next slide. Yes, so let's go directly to the third slide. Yes, I have. So you can see that we need to ask ourselves a fundamental question, not just in surgical care, but in healthcare delivery overall. And it is, who do we attempt mostly to receive quality health services? We have seen for decades that quality, expensive treatment options have been reserved for the wealthy in high-income countries, while the poor in low-income and low and middle-income countries have only been considered for cheap, low-cost prevention, health education, and treatment option for fake reason of cost effectiveness. Even WHO fell in that trap that we should not invest more than 4 times the GDP of a country in the health of an individual. That means if you are poor, you deserve poor care. And this is valid also for the poor in high-income countries. So we need to continue to fight to provide holistic services for all across a continuum of care that include surgical care, a neglected part of services. A critical component of this is challenging the double standard. You have to understand that. If we treat you poorly because you are poor, that is typically double standard, and focus on quality healthcare. We must focus on prevention just as much as on treatment. And we need to follow the same international standard for all. If you are in a low and mid-income countries, if you are in high-income countries. And we have to question and challenge all institutions or all individuals who say the contrary. So we need to question double standards, such as what WHO has done in early policies for MDR, multi-resistant TB, when they say that the poor in low and mid-income country cannot receive the expensive treatment that was the only one that was treated MDR TB. So they purposely give medicine that doesn't work to people living in low and mid-income countries. Furthermore, we need our equipment and infrastructure to be innovative enough to adopt new style of service delivery that are of quality and negotiate for the best drugs and vaccine. For instance, in Rwanda, we negotiate with Merck on providing HPV vaccine when it was new. And when at that time, no country has really a working national program for HPV vaccine delivery. And we managed to give the vaccine to all girls age 12, because it has to be done before the first sexual intercourse to be the maximum, for the maximum efficiency. And this campaign successfully vaccinated 93% of all the girls the first year, and this percentage, this rate of success is continuing since more than 10 years now. So we had opposition because people say, no, too expensive, you are too poor, you don't have this, you don't have that. So everything was an excuse not to make it, and we make it with success. For surgical care, it is the same. Our commitment to healthcare need to go beyond prevention. I say we need to associate prevention and care. We need to focus equally on treatment as well, regardless how expensive it is. Money is an excuse. I never found an obstacle that was really the money. I found obstacles and challenges by people who are dictating fake rules not based on equity. And for example, I can show you here what we do at Butaro Cancer Center treatment as an example of an institution that provides quality care even in rural poor setting. I can also give, this is done at the hospital that is transformed to be our teaching hospital. I can also give you other example how money can be overcome through solidarity. During COVID, during the lockdown, we never stopped educating at UJG. But because we were no longer traveling across the country, our cars and buses were not used. So we used them to help people from across the country to join the cancer center at Butaro Hospital for their treatment. And I know, for example, that so many patients didn't get surgery because of COVID, because of non-availability of the services. Everything has been taken over by COVID. And also because of reducing the demand at that time. And I'm sure during these conferences, you will talk about that, because when you create a resilient health system, and you create resilient health system not in period of crisis, you're creating it on day-to-day basis. That's why I show you the example of the cancer treatment at Butaro Hospital. It can continue to function because we build it patient-centered, and we build it so that everything is done to assure continuity of a continuum of care. And when there is a threat like COVID, what we have built during a period where we were not stressed by health threats pay off. So, next slide. If we look now at surgical disease burden, we see that there is a growing need for quality surgical care. Here is, I can provide you with some statistics to provide some context. Injuries are the leading cause of death among children. As a pediatrician, I am really stuck with that. For under 5, it's the leading cause of mortality, with sub-Saharan Africa having the highest under 5 mortality rate due to that cause. And children are dying because care is not there when they need. Additionally, we have 1 to 2 million maternal deaths per year in low-income countries that could be prevented through improved trauma care and surgery. And maternal death, when a child lost his mother, the chance of survival for this child are really diminished. So Africa has the highest ratio of surgical dailies per 1,000 people. And it is important because poor access to high quality surgical, obstetric, and anesthesia care contributes to 1/3 of deaths worldwide. Lastly, it's important to know that 70% of deaths following emergency general surgery happen in low and middle-income countries. This shows that there is a clear need for improved, accessible, quality surgical care in low and middle-income countries, and especially in Africa. This is especially critical given the epidemiological transition we face in sub-Saharan Africa the last years. As you can see from the graph on the right, the percentage of death and disease adjusted life year attributed to non-communicable or to maternal and neonatal and nutritional disease is decreasing, while the percentage attributed to non-communicable disease is increasing. And given that many of non-communicable disease require surgical care, it is even more obvious why we need to develop quality surgical services available to all. Despite these great needs, the disparities in access to surgical care are enormous. The percentage of the population that had access to safe, affordable, and timely surgical care is 90% in high-income countries, compared to 7% in sub-Saharan Africa. We can also take the example of C-section. WHO recommends an optimal range of C-section rate of 10 to 15. But the average rate of C-section in sub-Saharan Africa is only 7.3%, around half of the needs. And this explains the high rate of mortality. This suggests that women who require surgical care are not able to access it. Providing access to surgical care requires successful accompaniment of patients, meaning be with them and make sure that there is a continuum of care. We need to provide holistic care services to mother and infants. Here, taking the example of C-section, we need to provide quality antenatal care services, safe, timely delivery through C-section if the mother requires surgical intervention, quality post-operative care, postnatal visit and follow-up of the child that include critical childhood vaccination. If we don't do that, even if we provide quality surgical services, we may lose the mother or we may lose the child. So we cannot escape any steps in the process because we will jeopardize the health of the mother or the health of the child. And this is very important, meaning we should not go only to educate surgeons. We need to educate them and create the system where they can provide the quality service they have been educated for, and to protect those services and the patient by providing the chain of service delivery the patient needs. Surgical care goes beyond the operating room. This is what I wanted to explain in the previous slide. We need to provide quality care to patients before, during, and after the operations. At all stages of the process, we need to make sure that care is of quality, is accessible to all, and affordable. Otherwise, the success of the surgical operation will be undermined if we miss one of those steps. For instance, a patient who has undergone successful surgery but does not receive close post-discharge care will not recover well. True accompaniment of patient goes beyond providing quality clinical services. It includes support to access and enjoy it. We need to consider factors that enable patients to seek these services and to stay healthy. And those that are obstacles to that, we need to make sure that we overcome them. So we need to assess what we are doing and the context on which our patients are living. Sorry. This means to analyze the social determinants of health. This means to analyze the contexts that are facilitators and the contexts that are obstacles to quality care. For instance, is the mother able to travel to the health facilities for all the antenatal clinic to deliver there? Is there a system of transport when she's in labor and she cannot walk? Can the family afford the surgery? Does the health facility have the equipment needed? Does the mother and the child have enough food or access to balanced diet? There is no point of making these health services available at the hospital if the patient cannot reach them, or if they are not able to keep themselves healthy because of lack of food. This is why accompaniment is critical. This is why an holistic approach is key if we want to address the challenges that stand in the way of people to achieve their maximum health potential. Often, the majority of the time, what gets in the way of patient accompaniment is not the lack of knowledge. we know what to do for safe and effective evidence-based intervention implementation. But it's the lack of know-how, how to implement. For instance, 170 years after the invention of modern anesthesia, over 93% of the population in sub-Saharan Africa still doesn't have access to safe, affordable, and timely surgical care. I can also give you another example. 10 years after the development of safe surgical checklist, utilization rate widely differ, with high-income countries reporting an utilization rate of 90%, while this percentage in low-income countries is 30%. So implementation research are key and should be done by each and every one of us at point of care, at any point of the chain of delivery of care, so that it can help us identify and bridge the gaps. We are all familiar with the research that goes into the discovery of different medical products. But these medical products are transformed with the private sector in products that people can buy or government can buy. And this is still not turned those products in health outcome, because we need the people to receive it. So, for example, COVID vaccine were discovered very quickly. It was really a scientific performance. They were developed in a year to respond to COVID crisis. When that successfully discovery exists, funds are channeled to production with the private sector. That I want to say, by the way, that they made so much profit that the rich became 600 times more rich after COVID crisis compared to before, when the rest of the world became poor. So having this vaccine produced don't mean that all had access to them or that health outcome improved for all. Implementation science providers don't know how to assure effective implementation of evidence-based intervention. In my country, we have more than 60%, around 70% of the population that is vaccinated today. And among the non-vaccinated, we have many. We have a high percentage of under 5, the people, Rwandan, who should not be vaccinated. So this happened because of knowing the context in which Rwanda is and overcome the challenges, the contextual factors that are challenges, and leverage the facilitators to make it happen. And we should do that to increase the usage of the safe surgery checklist. Beyond bringing the gap between the discovery of evidence-based intervention and the effective and equitable implementation, we need to build resilient health systems that are able to continue provide surgical care during emergency and threats like COVID. The world has shown that majority of countries have failed. During COVID-19 pandemic, we have witnessed cancellation of surgical services in your country, in Ireland. I will say that in French. There were 70% fewer emergency surgery in 2020, and elective surgery were suspended in 46 out of 50 centers in Nigeria in the same year. So it's not a place or another. COVID has shown us that if we want the people to benefit with a continuum of care, of safe, quality surgery, we need to create a resilient health system. And for this, We need health systems that are aware, adaptive, diverse, integrated, and self-regulated. Those are the definition of resilient health system. So you see, educating surgeons is not enough. Having equipment is not enough. We need also to have systems that allow the educated surgeon to provide the quality care they have educated to provide. And for this, resilient health systems are key, because COVID is not the last threat we will have. At the national level, we need countries to design national surgical, obstetrical, and anesthesia plan and integrate them into national health strategic plan. We need a coordinated integration if we want the population to benefit in a continuous manner. Currently, there are only 6 African countries that have done so. Developing such strategies as part of the national plan will ensure their integration into the country health priorities and allocation of resources, because there is a plan. You cannot allocate if there is no plan. And those plans need to take in account how many surgeons should I educate, equipment I should procure, space I should develop to proceed to operation, etc. And beyond the national level, we have seen advance in global surgery movement to increase access to quality surgical care. This global movement brings with it several opportunities that we should all build on. Because it highlights the importance of including surgery in the global health agenda. You may remember that surgery was once termed the neglected stepchild of global health. It's true, it's still true. It can also help address the unmet need for surgery in low and mid-income countries, where there is a shortage of skilled surgeons. It can provide an opportunity for cross-learning and training of surgeons in low and mid-income countries, and the possibility of strengthening surgical training program and the opportunity to expand research in surgical care. However, this global surgery movement comes with its own challenges. Funding is not always aligned with global surgery care requirements. Moreover, we have surgical missions that are coming from the high-income country when they want, not necessarily when they are needed. And they interrupt daily functioning of hospital in low and mid-income country. They also undermine confidence of local surgeons who are not integrated, when they are not integrated. And some of these programs do not prioritize knowledge transfer or exchange and skill development, but rather focus on looking at one patient at a time or quick one-time fix, but not building system. And before, in the previous slides, I expressed to you why building system is needed for continuum of service delivery in global surgery. Ultimately, some of these programs provide more benefit to high-income countries' trainees who come to be trained than low-income countries' surgeons and their patients. So these missions need to be reassessed. If not, they will continue to be part of colonization in global health. So such challenge especially highlight parallel between the current approach to global health and colonial medicine. During the colonial era, the goal of colonial medicine was to keep the colonized healthy enough to work through a control rather than a care approach. health systems were primarily designed to take care of the colonial administration, the colonizer. We can take two examples. In Rwanda, when the treatment for plague was only afforded for the white people, the colonizer. They have access to hospital and their houses have to be disinfected and clean. However, when somebody, a Rwandan, was infected, he was not allowed to go to the hospital and their houses were burned. This was the law. We can see very unsettling parallel when we look at global health funding. Note that the disease burden from traumatic injury in sub-Saharan Africa is greater than the disease burden from TB, HIV, malaria combined. However, 50% of the US spending in global health program are dedicated to HIV/AIDS alone. I don't want money to be removed from HIV/AIDS program, but I want this money to be used freely by countries to strengthen the system as a whole. This makes us question the objective of global health initiative and whether they are more focused on preventing the spread of contagious disease from low-income countries to high-income countries, rather than save life of those in low and mid-income countries, regardless of what caused the illness. Because we should go, when we build system, to focus on how to save the majority of the people. So surgery should never be neglected. A critical challenge that we face in Africa and the globe is the shortage of healthcare professionals who are able to provide quality care. In Africa, we have 24% of the global burden of disease, but we have only 3 to 4% of the world's healthcare workforce. And it's a global issue, that's true. But don't forget that rich countries push to brain drain the people we educate at high cost when we are a poor country. The brain drain costs us $2 billion in a study done in the first part of the year 2000, the first year of 2000. And if you think that if I own a football club, I educate a footballer, and another club want to steal it, they have to pay me back for what I have invested. But here, high-income country pretend to help us educated people, and after that steal it for free. And we should have law that protect Africa, that the investment we do in education is done in quality service delivery because the workers are not stolen. If we look especially at the density of health personnel by 10,000 population in Africa, we will see that we are far from the number needed to achieve universal health coverage by 2030. If we are aiming to provide quality care, including surgical care to all, we need to address this shortage, and it's critical. We totally understand that the rich countries also lack health professionals, but it's not a reason to steal our investment. We can look also, especially at the shortage of specialist surgeons. It's enormous. When we compare the data for sub-Saharan Africa with that of North America and European Union, we can see that there is a clear inequity in access to services. And this shortage of healthcare professionals is a challenge we are working to address in my university, the University of Global Health Equity. We are combating inequities in health through reimagining global health education. And we have built our university in the rural north of Rwanda because we know that educating young talents in rural area make them accepting more easily to work there after graduation. And normally they are educated in cities and have problem to go back and work in rural area. So if there is we lack health professional over the world, and especially in low and mid-income country, rural area lack even more because health professional in low and mid-income country are more concentrated in cities. So as public health professionals working to enact change, we need to make sure that the next generation of global health leaders continue in the path that we have started by pushing them to go where they are the most needed. We also educate doctors for free in exchange of 9 years of public service for their full salaries. It's called Umusanzu agreement. They work for their full salaries, but where they are needed in public sector during 6 to 9 years, according the difficulty of the appointment. If they work in a refugee camp, it's 6 years. If they work in a district hospital, a very comfortable way, they will work 9 years for their full salaries. And we all know that the salary of doctors are among the 4 first salaries in low and mid-income countries. So at UJG, we aim to change the way healthcare is delivered across the globe by training the next generation of healthcare providers to care for the vulnerable and provide quality care to all. And when I say focus on the vulnerable, it's really focus on the vulnerable, those who cannot access for financial reasons or geographic reasons. We train our students not only in clinical skills they would need to treat patients, but also in both biosocial approach, the need for adequate diagnosis and treatment, because we cannot separate people with understanding the social determinant of health and what makes them sick in the environment and what makes them not accessing to care. So anthropology, history of Africa, etc., we train them in that. We provide them with the management and leadership skills that are crucial to repair, to build, or to manage quality health systems so that they can be great advisor of ministers or mayor to build the needed health services at national level or at the centralized level. So we hope to ensure that Rwanda's progress in health sector is maintained and continue to grow with that. But we have already educated people from more than 25 countries, so it's beyond Rwanda. And this year we have recruited medical students in Congo, Burundi, Kenya, Tanzania, Uganda, and we are expanding to Africa as we grow. So one of our initiatives that is helping us to get closer to achieve our goal is the Center of Equity in Global Surgery. This center was recently launched in last February on our campus with various partners because it's a global initiative with a global partnership. It is important to have a center such the Center of Equity in Global Surgery within institutions like UJG, a low and mid-income country in Rwanda, and in a remote rural area in Butaro. And our teaching is integrated into the community to ensure that our students learn from the ground reality. Note that it has been shown that training African residents in high quality residency program in rural setting help to retain them in rural hospital as well. Moreover, we have an history of delivering high quality, equity focused education through our medical program, because all our doctors are trained in the master in global health service delivery to be able to create the system where they can provide the quality clinical skills that they have learned with us. Many doctors go back in rural area and cannot deliver service because there is no system. So we train our students to create the system they need to provide the service, the quality service they have learned. We have many existing international, private, public, and academic partnerships that we can leverage to facilitate the work of the center. And we focus on practical, contextualized experience that will make our students great leaders in the future. Beyond teaching quality clinical skills, UJG embed leadership and management and communication training into all curricula, allowing all students to graduate with a mini MBA and managerial skills and advocacy skills also, so that they can convince their bosses, their colleagues, and also the patient to increase the demand and the service delivery. Such training is critical to bridge the current gap. We know that evidence-based intervention are successfully implemented if we create such condition. This center has several key pillars on which the work will be based. The fellowship component will provide equitable opportunity for outstanding individuals to train in global surgery in an innovative low and middle income country context. They will be mentored by diverse accomplished faculty. UJG will serve as a regional community-based global surgery fellowship site in partnership with other renowned global surgery centers. We will continue to research in global surgery from an institution and with investigators physically located in the environment it aims to serve. We will serve as a center of excellence to help African countries to develop national surgical obstetric and anesthesia plan and monitor outcome and evaluate them for ongoing opportunity for improvement. We will serve as an African hub for collaboration and exchange of ideas, and we will provide various education programs such as the MGHD with the global surgery track and stimulation-based training. I thank you for your attention and look forward to your questions.
Thank you so much, Professor Agnes, for this inspiring, eye-opening presentation, really. And despite all the steps that have already been taken, there is still so much to do to reach global health equity. We already have a few questions posted in the Q&A chat, and we have very limited time, so I'll just jump into that. So the first one is, a lot of effort has gone to the development of NSOAPs, but they have been hindered on the implementation side. In your opinion, in addition to incorporating the NSOAPs into national health plans, what are the best ways to bridge this gap?
So the best way to bridge this gap is an implementation science approach, meaning you need to analyze what are the contextual factors that are the challenges. Not only to constate that there is a challenge, yes, but what? So you have a national plan, you have a surgical council or group organization, you have the Ministry of Health, you have the entities that create the norms how to proceed. You have the Minister of Finance who dedicate budget to the health sector to implement that. So you need to do the chain and see what are the contextual factors that are obstacle and those who are facilitating and who can help you to leverage that. So that's the only way. So the implementation science approach to find the implementation strategies to get the desired outcomes.
Thank you very much for that response. Another question that we had is that last week we heard from the Global Fund that they are seeking 18 billion from world governments to fight AIDS, TB, and malaria. How can we convince donors to invest in health system resilience as well? Is healthy resilience just not catchy enough?
No, it's not catchy because people, you know, it's create system that don't like it. Yeah, but my issue is, you know, come in my kitchen. If I want to create a resilient pizza, you will not oblige me to create a margarita. So it doesn't cost more to build HIV services, TB and malaria, that make the health sector resilient than to just create vertical program. So I will not complain to the global fundings. I will more complain about, let's learn how to create resiliency with what we have. HIV, why? HIV, TB, malaria has raised so much money. You believe that without HIV, TB, and malaria, we will get that money? Never. Now look a country like my country. With HIV, TB, malaria money, we build emergency ward, both ambulances, educate people. You know that we even create a strong residency in a surgery with PEPFAR money. In your kitchen, you are the boss. So be the boss of resiliency. And if you want to know how to create it, that's why we teach it. Because we have the proof in the pudding. You create one lab. We keep with everything you need for pre-surgery exam. And you say it's for HIV. It serves everybody. You create a very good theater. And you say, yeah, it's because HIV people need surgery and they are more fragile. It serves everybody. So lack of imagination is the problem. Take the money and use it well.
Thank you so much for that important and strong message. Yeah, I believe it will be taken to heart. Unfortunately, we only have a minute left and there are a few more questions, and I was hoping to manage to ask you a few questions. This would be a very fascinating conversation, but unfortunately we have to move to the next part of our day, of our session today. Thank you so much, Professor Agnes, for your presentation today. It has been indeed insightful, and we are very grateful that you managed to join us here today.
It was my pleasure.
Thank you. And I will hand over now to my colleague, Dr. Jakub Gajewski, who is the Director of Research Program at RCSI IGS. He will introduce the rest of abstract presentations for you today. Thank you.
Thank you very much, Ines. And welcome everyone to our next abstract session. I am sure that we have all enjoyed the previous talks, but this session is very special and I am very excited to be hosting it for you this afternoon. It has three elements. Firstly, we'll listen to three excellent research presentations, but apart from that, at the end of the session, we will be announcing the winners of our best abstract competition. And following, we'll have a short Q&A session. But first thing first, so let's hear our presentation number one, which is going to be delivered by Dr. David Rapp, who will be talking about the financial impact of urologic conditions in men and women in Belize, which is a very small but very beautiful country in Central America. Please remember to feel free to ask questions in the chat box. As I said, we'll have our Q&A session at the very end. Over to you, David. Thank you.
My name is David Rapp from the University of Virginia and of Global Surgical Expedition. We are presenting our work here today, Financial Impact of Urologic Conditions in Men and Women in Belize. The Lancet Commission on Global Surgery was purposed to promote widespread access to safe and high-quality surgical care. The Commission reported that 5 billion people lack access to safe and affordable surgical care, and not surprisingly, the largest burden of this existed in low and middle-income countries. The Commission identified core indicators to both help prioritize global surgery initiatives and track progress towards care delivery. Notably, in addition to outcomes focused on care access and mortality, the core indicators also included focus on economic impact of surgical care. This focus on economic impact of surgical disease is important. Much literature is available to understand the impact of untreated surgical disease on morbidity and mortality as well as disability. Yet less emphasis has been placed on its devastating economic consequences. These can be macroeconomic and also microeconomic, of which much less is known about the impact of surgical disease. Microeconomic impact can occur through direct mechanisms such as cost of healthcare expenses, but also indirectly through secondary mechanisms such as the inability to work and loss of productivity, as well as inability of caretakers to work as well. At the same time, urologic disease is highly prevalent in low and middle income countries. A significant portion of the global surgery burden is urologic, and related surgical care is shown to be extremely cost effective. Despite this, there is limited data to help us understand the impact of urologic disease on ability to work or to quantify the related financial analysis. The present study was conducted to help understand these indirect microeconomic impacts with focus on urologic disease in the lower middle income country of Belize. Our study objective was to describe and characterize the impact of urologic disease on work function, family care, and financial well-being in patients in Belize. Patients were recruited during 3 consecutive visiting surgical trips by Global Surgical Expedition. GSE is a medical charity providing surgical care internationally to populations in need. Since 2012, GSE has provided over 400 urologic and urogynecologic surgeries in Central America and Africa. As part of GSE's trips, prospective surgical candidates are initially seen during a large triage clinic at trip initiation. Patients diagnosed with urologic disease during this clinic are recruited to participate in the present survey study. Patients completed a 17-item survey with focus on impact of urologic disease to both work and caretaker responsibilities, as well as economic impact. The primary study outcome was income loss resulting from work impairment or work time missed. Income loss was calculated using the validated Work Productivity and Activity Impairment Questionnaire, which is a validated assessment tool designed to assess the financial and quality of life impacts of medical conditions. Secondary outcomes included percent work time missed, percent work impairment, and percent overall work impairment due to urologic disease as measured through the WPAI. Additional secondary outcomes included items focused on general negative impact of urologic disease on work or caretaker responsibilities. Between 2019 and 2021, 114 patients completed survey assessment. Of 114 patients, 61 were working on a regular basis and thus able to provide sufficient financial data for analysis. Primary urologic disorder diagnoses are presented in Table 1. The most common was pelvic organ prolapse, as well as BPH and urethral stricture. Urologic distribution was similar across the cohorts. Questionnaire responses assessing the impact of urologic disease on work or caretaker responsibilities are presented in Table 2. A vast majority of patients reported a negative impact of urologic disease as related to time off from work or time off for doctor's visits. 9 patients, or 7.7%, were unemployed secondary to their urologic disorder. Notably, 89% of patients reported that treatment of their urologic disease would improve their ability to care for their family or perform their job. Table 3 demonstrates the WPAI and financial analysis for this subset. Across these patients, mean percent work time missed and percent work impairment while working due to urologic disease was 21.8% and 42.0%, respectively. Mean weekly income was $461 in Belizean dollars. Accordingly, the percent overall work impairment resulted in $59.10 per capita in lost income weekly, thus representing a 12.8% total income loss attributable to urologic disease. Subcohort WPAI analysis for oncology, obstruction, and female urology cohorts are also shown in Table 3, demonstrating significant variability in mean percent work time missed, percent impairment, and mean income loss across cohorts. Accordingly, the mean percent work time missed and percent impairment while working was greatest in the obstruction cohort. We hypothesize that this relates to the frequent need for care visits to doctor offices to have urethral catheter changes, which is a common occurrence in these men with BPH or stricture disease chronically. Loss was greatest in the oncology cohort. Notably, given the 12.8% total income loss, 88.6% of patients reported that cure of urologic disease would increase the ability to work and care for family. In conclusion, in Belize, urologic disease results in significant work impairment and work time missed. This impairment is associated with a significant level of potential income loss. In addition, urologic disease results in problems caring for family in a significant portion of patients. Efforts to improve access to urologic surgeries in low and middle income countries is important as they promote benefits not only to quality of life and morbidity, but also to economic health and well-being. We would like to thank the University of Virginia Center for Global Inquiry and Innovation for support of this project, as well as Global Surgical Expedition. Thank you for the opportunity to present here today.
Thank you, Dr. Rapp. That was really excellent. And let me introduce our next speaker, who is Louise Atadja. She will present the qualitative analysis of experiences of patients receiving orthopedic treatment at a hospital which I know very well personally, which is Kamuzu Central Hospital in Lilongwe in Malawi, a country which is often called the warm heart of Africa. Over to you, Louise. Thank you very much.
Hi, my name is Louise Atadja. I'm a fourth-year medical student at UT Southwestern. Today, I'll be talking about the experiences of adult patients receiving treatment for femoral shaft fractures at the Kamuzu Central Hospital in Malawi. I have nothing to disclose. So the global burden of trauma is very high. The late Paul Farmer used to say that global surgery is the neglected stepchild of global health. And so when you compare deaths for trauma compared to communicable diseases like tuberculosis, malaria, HIV/AIDS, we actually see a higher amount of deaths from trauma compared to these others. There's also a rising incidence of injury disproportionately in low and middle income countries. And as you can see, it's been rising significantly over time. We've focused our project on Malawi, a country in Southeastern Africa, which has a population of about 18 million individuals. 83% of Malawians do live in rural areas, and about 51% do live below the national poverty line. Malawi has the 4th highest road mortality rate worldwide, and deaths, injuries on the road are very common. These can be very devastating, especially for the poor who need their extremities to fish, build, farm, anything to bring food on the table. And so a fracture can really be all that it takes to be a significant loss for families. And there's obviously a big need for orthopedic surgery care, but as you will see, basic access to essential orthopedics care is not available. So over 90% of people in sub-Saharan Africa and South Asia do not have access to safe and affordable surgery, compared to 4% in high-income countries like the United States and the UK. In the United States, there's about one orthopedic surgeon for 11,000 Americans, compared to Malawi, which has one orthopedic surgeon for every 1.3 million people. And so this is the result. Crowded wards are filled with patients who have been waiting for proper care and proper treatment like surgery and for many days. And the public hospital system is divided into rural care, where you'll get your basic first aid, maternity care, district hospitals, which are staffed by general doctors and orthopedic clinical staff. And then you have your central hospitals, which do provide surgical specialty care. And so skeletal traction versus interventional now. So operative treatment for femoral shaft fractures are the international gold standard, but this, as I said, is only performed in central hospitals. And for skeletal traction, about 90% do receive delayed hospitalization, 20% do receive complications, and about 9% actually do die in the hospital. And so in our study, we did a qualitative analysis. One of my co-authors, Dr. Kiran Agarwal, performed interviews on about 16 patients while inpatient. These interviews were recorded and transcribed and asked about their experience in the hospital, both pre-hospital, post-hospital, and as they were waiting for further care. We then coded the transcripts and performed a thematic analysis. And so here is just the general demographic data for our patients. We had both rural and urban setting for injury, and occupations were very across the board. In terms of mechanism of injury, it was about 50-50 for fall and road traffic injuries. But then for current treatment, the majority of patients, whether skeletal or skin traction, were being treated non-operatively, with only 3 patients who had received surgical treatment. And then in terms of complications, we had about 33% of patients who did have non-union. We decided to record 2 patient experiences as shown here. Patient 9, he was injured after a fall from a motorcycle, presented at the health center and was placed in skin traction for about a month. Was then referred to Kamuzu Central for an x-ray and was placed in a cast for about 1 month, discharged home in that cast. And then when he returned for cast removal, he was then diagnosed with non-union. And so he's been awaiting surgery with no immobilization for about 2.5 months. And this is about 5.5 months from his original journey. Comparative to this other patient, patient 16, around the same age set. And while he was injured in a motor vehicle crash, presented to a local health center and then to Kamuzu Central. And after a day being hospitalized in a splint, he then self-referred to a private hospital. And then after being in a splint for 1 day, he did receive surgery. And so we identified 6 themes from these interviews. We found a high variability in health system navigation. Patients are frustrated with the biopsychosocial effects of being hospitalized for so long, the lack of agency and communication about the treatment course, a preference for surgical treatment based on what they're seeing in others' experiences, frustrations with seemingly rationed care, But we did find that patients had a sense of resilience in the face of these hardships. So we did select some quotes that we thought represented each theme. So they're in terms of high variability. One patient talked about wanting an explanation for why some patients have been here 5 to 6 months. Some have been here for only 6 weeks. We wonder why so many different things are happening that are unfair. In terms of frustrations with hospitalization, one patient says, when I was home, I was able to go to school. I've been stationary here for a month. This place is like a detention or prison. In terms of limited patient participation in decision-making, one patient said, it may risk my life. I can't speak about my difficulties with treatment, or they will hate me more and stop treatment. In terms of preference for surgery, one said, the treatment skeletal traction is not effective. I want to go home. This is more painful than the surgery itself. It's not helping because I can't sleep. I'm always in pain. I'm always crying. I'm not happy because I'm not healed. In terms of inequitable provision for surgery, one patient said, some patients are well known and well-to-do, and that they can't be in the hospital wrong. I feel most pathetic because we're poor. That's why we're still in this state waiting for surgery. And then in terms of acceptance by submission and resilience, one patient noted that I'm expected that I will get a better treatment, surgery, and I'll be okay. I'm expecting that things will change. And so just to summarize, we found that many patients receiving non-operative treatment described the devastating financial burden imposed upon them and their families by injury and prolonged hospitalization, not being able to go home, to work, to go to school. It did have a major effect. And then patient also felt that they were receiving inferior treatment in terms of skin and skeletal traction compared with patients who did receive surgery. And they suspected that richer patients were receiving a more timely care.
Thank you, Louise. That was really interesting. And lastly, we have Eitaya Owolabi presenting a qualitative study about social determinants of seeking and reaching injury care in South Africa. So over to you, Eitaya.
Good day, everyone. My name is Eitaya, a postdoc fellow at Center for Global Surgery, Stellenbosch University, South Africa. I will be presenting findings from our community-based study looking at the social determinants of seeking and reaching injury care in South Africa. To sort of provide some background to the study, South Africa has a very high rate of injury, estimated to be 7 times the global average, and mostly due to interpersonal violence and road traffic accidents. Also, injury-related deaths in South Africa is 6 times the global average. However, injury-related deaths and disability can be reduced if pathways to care are optimized and delays are reduced. Talking about delays in accessing care, the 4 delays framework has been adopted by several studies in describing access to care, including injury care. And this framework describes delay in accessing care in 4 phases. Delay 1, delay in seeking care. Delay 2, delay in reaching a healthcare facility. Delay 3, delay in receiving definitive care. And delay 4, delay in remaining in care to achieve optimal function. For the sake of this study and presentation, we are focusing on delays 1 and 2. To sort of understand barriers to accessing injury care, we looked at it from the social determinant of health perspective. And social determinant of health are factors or conditions in which people were born, live, or work that may influence their health, health-seeking behavior, health outcomes, and even their quality of life. And this has been divided into 5 domains: education, access, and quality, economic stability, healthcare access and quality, neighborhood and environment, and lastly, social and community context. The role of social determinants of health on the incidence of injury is well highlighted. Also, their roles in health-seeking behavior for some health conditions such as maternal and child health is well known. However, the role of social determinant of health in accessing injury care is unknown. Therefore, the aim of this study was to determine the social determinants of seeking and reaching injury care in Western Cape, South Africa. Methods. We adopted a descriptive, exploratory, qualitative design, and the study setting was Western Cape Province of South Africa, specifically at a rural and an urban site. The participants were individuals with history of injury who received care in the study settings, healthcare providers involved in trauma care, as well as community stakeholders. Participants were 18 years and above, and they were all recruited purposively and conveniently from healthcare facilities and within the communities. Data were collected through semi-structured individual interviews and focus group discussions. Data were analyzed thematically, following a deductive and inductive approach. The study was approved by Stellenbosch University and University of Birmingham Research Ethics Committee. Result. A total of 20 individual interviews were conducted and 2 focus group discussions involving 30 participants. For those in the individual interviews, we had 13 males and 7 females. And for those involved in focus group discussion, we had an equal gender distribution. This figure summarizes the barriers to accessing injury care in our study settings, and we can see that these barriers cut across the 5 domains of the social determinant of health framework. However, a large portion of them were related to the healthcare access and quality domain, closely followed by those related to neighborhood and environmental domain. Pertaining to barriers related to healthcare access and quality, this included perceived poor quality of care as well as long waiting times. Participants indicated that the quality of care provided at many of the healthcare facilities are suboptimal, and sometimes healthcare providers lack empathy towards patients, and that discouraged people from seeking healthcare, including those who are injured. Also, participants experience long waiting times at the healthcare facilities. This is often unacceptable, and this discourages people from going into healthcare facilities to seek healthcare following an injury. Therefore, they would rather engage in self-medication. In addition, the neighborhood and environmental barriers included high crime rates, fear of attack by gangs, and lack of alternative transport options. In our study settings, some areas are designated as red zones or danger zones. Individuals who sustain injury in these areas are often reluctant to seek healthcare because of fear of being attacked on their way to the healthcare facility. Even ambulances are reluctant to pick patients up from those areas, and whenever they need to do so, they require police escorts, which results most times to delay in reaching care. Also, social and community barriers that impacted injury care included social support and alcohol use. For individuals who had social support, they were able to reach and seek care in a timely manner. But for those who did not have social support, access to care was often delayed. Alcohol use was a major barrier to accessing injury care. Those who sustained injury under the influence of alcohol either did not know that they had sustained injury, or they delayed seeking injury care because they felt that the injury was minor, and they only sought care when the symptoms worsened. Other identified barriers were those related to level of education, and this impacted the perception of the severity of the injury. Likewise, economic status of the individuals impacted accessing injury care. For those who were poor and couldn't afford alternative transport, they were forced to wait on the ambulance before seeking care. Discussion. Timely access to injury care is very crucial to improving outcomes. Our study showed that social determinants of health not only impact the incidence of injury, but also the ability to access, to seek, and to reach timely injury care. Some of the identified barriers like perceived severity of injury were also highlighted in other studies, but those related to neighborhood crimes, alcohol use, negative perception of health system are specific to our setting. A lot of the participants emphasized on the lack of empathy by the healthcare providers. It is therefore important for healthcare managers to reinforce the importance of patient-centered care and communication to improve access to injury care. Our study was limited to only one province, thus the findings should be interpreted with caution. In conclusion, neighborhood, social, and community factors play a crucial role on seeking and reaching injury care. Therefore, efforts aimed at improving access to injury care and outcomes must go beyond addressing healthcare factors to include social determinants of health and other relevant stakeholders. I would like to acknowledge the National Institute for Health Research for funding this research, Center for Global Surgery, and our study participants. Thank you.
Thank you very much, Ataya. That was really excellent. It was very interesting to learn that the neighborhood factor, as you called it, had a role to play in the way patients can access care in the area where you conducted your study. So these were the three presentations that we had for this afternoon, and let me present to you the winners of our best abstract competition. I wish I had a little drum roll to play for you, just to increase the tension a little bit. But anyway, without further ado, the third place goes to Dr. David Rapp for the presentation that we just heard. Congratulations, David. The second place goes to Luis Ataja. Congratulations, Luis. And the actual winner of the best abstract competition at the first Dublin meeting on patient-centered care global surgery is our last speaker, Ataya Olabi. And I hope we can all give her a virtual round of applause for this excellent achievement. Thank you very much, Ataya. That was very good. I'd like to invite all our speakers to turn on your cameras and microphones, and we can move on to our session where we can ask you a couple of questions. Let me just check if we have any questions in the chat box. I don't see anyone asking a question yet, but I have prepared in the meantime a couple of questions for yourself. So let me start with Dr. David. Thank you very much for this interesting talk, and it is very important to provide those kind of surgical services that are lacking in the low resource environments, such as as in Belize. I was wondering if you could maybe reflect from your perspective on, what is the way to provide those services in a sustainable way, utilizing local capacity. Are there any efforts that your organization is putting in place to make sure that it is there is a transfer of knowledge from people as yourselves coming to help patients in those settings to the local providers, so they can eventually, with time, gradually take over from the external teams coming to provide those services?
Well, thank you for that question. Can everybody hear me? Is that good? Yep. Okay. Yeah. What an honor to be here talking today, and thank you for that award. That's a great question, and I think at the heart of every surgical trip, in particular visiting surgical trips, should be the commitment to sustainability in one way, shape, or form. As we all probably know, sort of fly-by-night surgical teams coming in and doing surgeries is not an ideal model and causes a lot of problems. So yeah, in our efforts in Belize, and we're also in Africa, we make very substantial efforts to pass on the knowledge, whether that is through lectures or through training local surgeons to do the surgeries that we do. There's a huge context of training involved in that. And we also, I think one of the most eye-opening things for me is if you go into these trips really with the country that you're there to help, as a priority, they will commonly tell you what they need, and you will also identify other opportunities. So you may go in saying, we want to provide this certain surgical service, but if your eyes are open, it may be something totally different that you end up doing. And so, for example, in Belize, where there's a tremendous amount of incontinence and prolapse, but there are no urogynecologists in the entire country, that is a little bit harder to train, although we do try to train general gynecologists to do those services. But one of the things, the opportunities for sustainability that we've found has to do with preventative services, such as pelvic floor physical therapy. And so we've now launched a huge program in that country to build a pelvic floor therapy center, train local providers, whether it's midwives or other people who are interested, so that they can provide this care moving forward and hopefully prevent some of the surgeries that we went down there to do in the first place. So I could give a lot of examples, but absolutely, sustainability is at the heart of what we try to do wherever we go.
Okay, thank you very much. That was very, very insightful to learn about the depth of your work and the focus on sustainability, which, as you say, is crucial. And you know, I think we all are aware that we should be diverting from this kind of parachuting models that where surgical missions are you know, achieve questionable results. Although people might feel good about the impact they make, but long term, it doesn't really make much of a difference on the ground, and kind of can have a detrimental effect on the actual healthcare system in that particular context. I was also wondering if you had any particular research challenges doing the study, because, you know, administering questionnaires to patients, asking them about financial aspects and income loss. There is a lot of sensitivities, and we have conducted similar studies, and it wasn't always easy. And I wanted to find out if you had similar experiences from Belize, because our work is predominantly based in sub-Saharan Africa, so I'm very familiar with that context. I have never worked in Belize, so I was wondering whether the challenges were similar or was it actually easy to do it? Maybe, I don't know. Sure. Thank you.
I mean, more globally, other than the interview, which is what I think you're focusing on, it was challenging. It was challenging because this project, which was grant funded, started right before COVID. So it was a major challenge to even get back into the country to be able to do this work in the first place. And we got very lucky. We had to have a preparation trip and meet with the Ministry of Health, but we finally got back in to conclude our recruitment at the end of last year. So that was hugely challenging. In terms of the interviews, you know, there's a couple people who are involved. It's not just the visiting teams. We have local providers and healthcare workers who are involved in the conversation. I didn't find so much the solicitation of the information and the sensitivity of it to be a barrier in terms of, you know, what you're talking about, and people sort of unwilling to give that information. I don't know if it's differences across the countries. I don't know if part of it's because we're there to deliver free surgical care. And so I think these patients who are going to be the recipients of that, you know, they were seeing us at the start of a surgical mission trip. So I think they're very grateful for that care and therefore potentially more willing. Talking about and defining what a job was, or what the income was, or, day work, that was very challenging because there were a lot of different definitions in terms of what we construed as work where they might not have. And so we had to do a lot of sort of qualitative discussions. It unfortunately was not one of these questionnaires that you can just give them and say, fill it out and then give it to me. You have to talk them through it. But ultimately, once you did that, we were able to get the information.
Yeah, okay, thank you very much. Yeah, that kind of resonates very well with the experience we had and the challenges that we have experienced ourselves. We have a question to ASI as well. So let me just ask you that one. It comes from Isabel Marks, and she wanted to find out, do you have plans to extend your work to other provinces and areas? Do you feel like your findings could be generalizable to other settings?
Well, like I actually said in the limitations, our studies was actually limited to one province, the issue of insecurities is actually a nationwide problem. And we might actually think that those problems might be present in other provinces, but if we have resources, we might actually plan to confirm that hypothesis by conducting studies in other provinces around the same topic.
Okay, thank you very much. And I wanted to ask you as well about the red areas that you mentioned in your presentation. I have heard similar mentions of it on another conference, and I was wondering, are there any interventions to help patients in this or potential patients in these areas to kind of strengthen or make the patient journey a bit easier, because the crime rates is obviously are very high, and that affects their kind of ability to move from one place to another. And as you mentioned today, the ambulances also, you know, the staff working in those ambulances are not particularly keen to go in those places. So I was wondering if you're aware of any interventions that are tackling that issue.
Okay, based on some of the comments from our participants, I think the community sort of have an arrangement whereby the injured people are moved into the nearest government building, like the fire department. And once they are able to get to that fire department, the community as well as the department is able to assist the patients in getting to the facility. Also, the EMS people, the ambulance people actually said that sometimes they negotiate with the people, the patient or the bystanders, to sort of move the patient to a more safer place or to a safer place to then pick the patient up. So the community is kind of putting in place strategies or interventions to assist, but I'm sure this is not optimal yet, but those are some of the measures that are in place in this community.
Yeah, okay, thank you. So the community is trying to adapt the way they can function to the context that they're in, right? From what you're saying. And I wanted to ask you also a similar question that I asked David about the actual implementation of your study, you know, because you use qualitative methods which have their own charms and beauties and difficulties, and talking to people about their sometimes traumatic experiences could be also very difficult, and you might not be able to create that space for people to open up and talk. And I was wondering, while you were presenting a presentation, you know, how did you find that in terms of, you know, administering the actual interview, and was it easy or not to conduct a study?
I think the research assistant who actually conducted the interview is a medical doctor. I think being a medical doctor sort of made the patient or the participant a little bit relaxed. And also the setting that was used for the interview was setting chosen by the patient, and some of them actually went to the healthcare facility. So it was sort of relaxing for them. And it was sort of relaxing. And also I see that when you do qualitative data and you want to interview patients, you must bring their own kinds to them. Like this patient, the people that were Black were interviewed by a Black research assistant. The ones that were of different colors were interviewed by that same race. So I think it makes the participants to be relaxed. It makes them to open up. And the fact that our research assistants were actually medical doctors helps a lot. So those are some considerations that can be put in place.
Yeah, thank you for that, because there is a lot of students also in RCSI who happen to do all those studies, and they always have those questions that they want to find out, you know, how best to do qualitative research, which seems easy at the kind of a surface level, but when you actually get to do it, it comes with a lot of challenges. So thanks for those insights. I think we are unfortunately at the very end of our abstract session. So congratulations to the 3 winners. We'll be in touch later on about what's next, and I will hand over to Professor Mark Schreim now to continue with the program. Thank you very much.
Thank you.
Thank you, Kuba. Thank you to 3 abstract presenters. Some very, very interesting science that's been presented all day today. I am here to make a couple of closing comments before our dean closes us off altogether. I want to thank all of you who've attended and who've stuck through these few hours. I want to specifically thank our 4 keynote speakers from last night, Dr. Mpoki Ulisubisia, and today we had Tantri Dr. Noor Hisham Abdullah, we had Dr. Agnes Binagwaho, and Dr. Alessandra Colainanni. Thank you to all of you for spectacular talks on all sorts of different aspects of patient-centered global surgery. This session, just like last night's session, has been recorded, and the link to the recording will be available to you all later. With that, let me turn over to our Vice-Chancellor for Academic Affairs, Dean Hannah McGee, to close us off for the day.
Thank you very much, Mark. And it really is a privilege for me to be able to close this really wonderful inaugural Dublin Meeting in Patient-Centered Global Surgery. I think the meeting has given us all a lot to reflect on, and I'm sure will spark conversations that will go on and maybe develop into projects and collaborations over the next few months. And indeed, as some of our speakers have said, a lot of challenges. I like the concept that we just heard recently of challenging poor care for poor people, whether it's poor care for poor people in our own country or in other countries. I think that's a real challenge for all of us, wherever we're listening from, to reflect on. It's been a really lively and interactive 2 days, and we've been really pleased to have had some people on campus yesterday and today. It's really nice to be returning to some of those in-person activities. And hybrid meetings of this standard take a lot of work to run smoothly, and the Institute of Global Surgery have asked me to extend their thanks to the RCSI events team, who've been working behind the scenes for many months to make this meeting to come to fruition, to make sure that you all got the invitation and you were able to connect and be here today. And I want to particularly thank Sheila Corbelis, Claire Phelan, Leila McCabe and Cara McVeigh for their tremendous and expert support in doing this. Also to thank our estates and portering team, who've made everybody on campus so welcome in the last few days and last night at the inaugural lecture for the event. And from the outset, the idea of this Dublin Meeting in Global Surgery was met with unanimous support from the senior management team and from council. And so I'd like to thank Professor Ronan O'Connell and Professor Cathal Kelly for them and their team's support and their ongoing commitment to global surgery. I also would like to thank Professor Camilla Carroll, who's our RCSI member of council and chair of the Committee for International Cooperation and Development, who expertly moderated the opening event yesterday evening with our guest speaker, Dr. Mpoki Ulisubisia. And within the Institute itself, you'll have seen all of the team really today, and most of the team, and I want to thank the whole team who contributed to this event under Mark's leadership. And I would like to particularly thank Deirdre Mangaoang and Fergal O'Rourke, who worked closely with Sheila Corbelis on the organisation, and to all of the team who served as moderators and facilitators throughout the day, and to everybody who formed part of the Abstract Review Committee. It was great to hear those 3 abstracts. The Institute's next event will be the Global Surgery Grand Rounds, co-hosted with UNITAR and the Global Surgery Foundation on Wednesday, the 6th of April. And I encourage you to keep an eye on the Institute's social media channels. And we'll share a closing slide here with all of the details on how you can find and continue to follow the Institute of Global online. And finally, all that remains from me is to wish you all, wherever you are in the world, a wonderful and a happy St. Patrick's Day for tomorrow, the 17th of March. And farewell to all of you, and thank you for joining us today.